ആ ഇതിനകത്ത് നമുക്കൊരു ബാക്ക്ഗ്രൗണ്ട് നല്ല ഇടാറുണ്ട് സാർ, അതെവിടെയാ? ഇന്നലെ അത് കണ്ടാണല്ലോ. ഇതിപ്പോ നമുക്ക് ഇതില്ലേ?
Namaskar, Suprabhat everyone. I am Vaidya Shukla Rajuri lecturer, PG Department of Panchakarma, National Institute of Ayurveda, deemed to be University, your host for today's morning from Jaipur. Today is Friday. The time is 10:40 IST. The purpose of today's gathering on this platform is national webinar organized by PG Department of Panchakarma, National Institute of Ayurveda. Before further proceeding, we would seek blessing from Lord Dhanvantri, our Adi Dev. For this, I would hand over the platform to Dr. Vaibhav Bapat, Faculty Panchakarma Department, NIA, and request Professor Sanjeev Sharma Sir, Professor Surendra Ved Pathak Sir, Dr. Gopesh Mangal Sir, Dr. Sarvesh Kumar Singh, Dr. Vipin Kumar for Dhanvantri Pujan, followed by Dhanvantri Vandana.
श्री गणेशाय नमः। ओम आत्म तत्वं शोधयामि स्वाहा। ओम विद्या तत्वं शोधयामि स्वाहा। ओम शिव तत्वं शोधयामि स्वाहा। ओम तत्सत् अद्वैतस्य ब्रह्मणो हि द्वितीय प्रहरार्धे श्वेतवाराह कल्पे जम्बूद्वीपे भरतखंडे राजस्थान प्रदेशे राष्ट्रीय आयुर्वेद संस्थान पुण्य क्षेत्रे कलियुगे कलि प्रथम चरणे प्रमादी नाम संवत्सरे कार्तिक मासे शुक्ल पक्षे द्वादशी तिथौ शुक्रवासरे पंचकर्म विभाग द्वारा अहम श्री धन्वंतरी देवता प्रीति पूर्वकम आयुष्य आरोग्य ऐश्वर्य अभिवृद्ध्यर्थम श्री धन्वंतरी पूजनमहं करिष्यामि। ओम अपवित्रः पवित्रो वा सर्वावस्थां गतोऽपि वा यः स्मरेत् पुण्डरीकाक्षं स बाह्याभ्यन्तरः शुचिः चतुर्भुजं पीतवस्त्रं सर्वालंकार शोभितं ध्यायेन् धन्वंतरिं देवं सुरासुर नमस्कृतं युवानं पुण्डरीकाक्षं सर्वाभरणभूषितं दधानम् अमृतस्य कमण्डलुं श्रियाम्युतं यज्ञभोगं भुजं देवं नमस्कृतं ध्याय धन्वंतरिं देवं श्वेतांबरधरं शुभम् आगच्छ देव देवेश तेजो राशे जगत्पति मया पूजा गृहाणं सुरतत्तमः श्री धन्वंतरी देवम् आवाहयामि। श्री धन्वंतरी देवाय आसनार्थे पंचपुष्पाणि समर्पयामि। श्री धन्वंतरी देवाय पाद्यं नमः। श्री धन्वंतरी देवाय अर्घ्यं स्वाहा। श्री धन्वंतरी देवाय चंदनं समर्पयामि। श्री धन्वंतरी देवाय धूपं समर्पयामि। श्री धन्वंतरी देवाय दीपं दर्शयामि। श्री धन्वंतरी देवाय नैवेद्यं समर्पयामि। पानीयं समर्पयामि इति उत्तरापोषणं हस्तप्रक्षालनं समर्पयामि। मुख प्रक्षालनं करोदर्शनार्थे चंदनं समर्पयामि। श्री धन्वंतरी देवाय सुवर्ण पुष्प दक्षिणां समर्पयामि। श्री धन्वंतरी देवाय प्रदक्षिणं समर्पयामि। नमः सर्वहितार्थाय जगदाधार हेतवे साष्टांगोऽयं प्रयत्नेन मया कृतः नमोऽस्त्वनन्ताय सहस्रमूर्तये सहस्रपादाक्ष शिरोरुबाहवे अनेन यथा मिलितोपचार द्रव्यै कृतपूजनेन श्री धन्वंतरी देव प्रियतां श्री धन्वंतरी देवताय नमः।
नमामि धन्वन्तरिमादिदेवं शूरासुरैर्वन्दितादिपद्मं मृत्युनाशं दातारमीशं विविधोषधीनां चव्योमवातावनिवारिवहनिं पंच प्रपञ्चात्मदेहभाजं संतापसम्पादजराज्वरान्तिकं नमामि धन्वन्तरिमादिदेवं नवीननीलं मुदिकान्तिकान्तं शान्तं हरे द्वादशमामूर्तिं पूर्तिं सदानां सुमनोरथानां नमामि धन्वन्तरिमादिदेवं नमामि धन्वन्तरिमादिदेवं नमामि धन्वन्तरिमादिदेवम्
May Lord Dhanvantri always bestow blessing on all of us and our near and dear ones. The theme of today's webinar is Panchakarma for Spinal Disorder and Insomnia. I would request Professor Sundeep Pathak sir, HOD PG Department of Panchakarma NIA, to deliver a welcome note and provide a brief insight of today's event.
Good morning. I am Professor Surendra Pathak, Organizing Secretary of this national webinar on Panchakarma for Spinal Disorders and Insomnia, organized by PG Department of Panchakarma, National Institute of Ayurveda, deemed to be University, Jaipur. I warm welcome to Honorable Chairman of this webinar and our beloved Director of NIA, Professor Sanju Sharma sir. Secondly, I warm welcome our today's guest speakers, Professor Murlidhar Pujar sir and Dr. Shibu Varghese. Then I warm welcome to the participants enrolled in this national webinar on various more than 20 states of India and also out of countries, and given good response to our this debate. As a BMS, MD, MS, PhD scholars, internists, Ayurveda faculty, teachers, and Ayurveda practitioners. This event is we organize on the 5th Ayurveda Day celebration. My experiences, 1 minute I share with you. We have chosen this topic, spinal disorder, because from the students, PG graduates, there is a demand, there is a need of a spinal disorder, how to treat by Ayurveda treatments. मेरा जो एक्सपीरियंस है इसके बारे में मैं एक बताता हूँ कि ये जो स्पाइनल डिसऑर्डर्स है ये मज्जास्रोतस के व्याधि है जो आयुर्वेदा में ग्रंथ में जो उसका उल्लेख मिलता है उसमें मन्नास्त्र है, खंज है, ग्रग्रसी है, विश्वाची है, So these are the some diseases come under the category of Majjavaskutas, and we have to keenly examination because the मूलस्थान of these स्रोतस ये मज्जावस्कुटस है, तो उनके जो मूलस्थान है रुक्क है, किडनी है, बाद में जो वसा है और अस्थि और संधियां, ये जो अस्थिवस्कुटस और मज्जावस्कुटस दोनों इधर मैं बोलता हूँ कि आपको थोड़ा सा इसका समावेश है कि अस्थिवस्कुटस और मज्जावस्कुटस, लेकिन मेनली जो आपको मिलता है वो मज्जावस्कुटस के अंदर है। तो मैं व्याधि विनिश्चय एक किताब है, तो उसमें आप जाकर आपको मिलेगा। कंफ्यूजन है कि ये मज्जावस्कुटस का व्याधि है या अस्थिवस्कुटस का, तो मेनली मज्जावस्कुटस का व्याधि है और बाद में ये उसका संबंध है कि अस्थिवस्कुटस का। तो आपको सूत्र मालूम है कि अष्टाश्रयाणाम व्याधिनाम पंचकर्माणि वेशजम बस्तेया क्षीर सर्पिशी पित्तोप हितानीचो। तो इसमें पंचकर्मा एक इसमें प्रमुख औषध या ट्रीटमेंट बताई है और विशेषतः इसमें बस्ती आप देना चाहिए और तिक्त वर्गों से सिद्ध किए हुए जो दुग्ध है वो और वृद्ध इसका भी प्रयोग इसमें कर सकते हैं। सेकंडली जो है कि मैं बता रहा हूँ कि मज्जावस्कुटस का स्पेशली ये व्याधि है, तो उसका भी आप मज्जा शुक्र समुत्थानम औषधम साधु तिक्तकम अन्नम व्यायाम शुद्धि काले च मात्रा याम। तो ये भी आप जरूर है कि हम पंचकर्मा का वेबिनार है, तो हम कौन से पंचकर्म कर सकते हैं, खाली बस्ती का प्रयोग करने से ये नहीं चलता है। तो ये प्रमुख सूत्र है, आप चरक सूत्र स्थान शीतपीति अध्याय में आपको ये मिलेगा, 28 नंबर का अध्याय है। तो इसमें बताया कि मधुर और तिक्त अन्नपान आहार्य पदार्थ रुग्ण के लिए आप एडवाइस करना चाहिए। बाद में व्यायाम, आप जो एक्सरसाइज है वो भी इसमें बताने के लिए बताया। प्रमुख जो है मेरा बताना ये जो है कि उचित काल में मात्रा से शोधन, मीन्स वमन और विरेचन का प्रयोग इसमें करना चाहिए। वसंत ऋतु में वमन और शरद ऋतु में विरेचन। तो इससे ये व्याधि ठीक होने वाले हैं। मैं क्लियर करना चाहता कि बस्ती है उसके साथ साथ वमन विरेचन भी है। तो ये सभी से ये बताइए, वात एक प्रमुख वात व्याधि में भी आता है। तो वातस्य उपक्रमः स्नेह स्वेग संशोधनम मधु, संशोधन मीन्स इसमें वमन और विरेचन आता है, और वमन और विरेचन से ही व्याधि ठीक होने चाहिए। और उचित मात्रा में, मात्रा में ये शुद्धि कैसी करना चाहिए, और काल ये ऋतु के अनुसार आपको इसका ये पंचकर्म करना चाहिए। सेकंड जो है इंसोम्निया, हमारा जो मिनिस्ट्री है, आयुर्वेद मिनिस्ट्री ने जो आयुर्वेदा पर कोविड-19 पेंडेमिक, तो इसके लिए ये 5th आयुर्वेदा डे का ये प्रयोजन करने के लिए बताया है। तो हमारा जो दूसरा जो व्याधि इसमें है कि इंसोम्निया, तो ये भी है कि मनोदोष जो आयुर्वेद में बताए हैं, तो ये 6 प्रकार के निद्रा है। तो स्वाभाविक जो निद्रा रात में जो आती है, तो उसमें जीवन धारण हो जाता है, धारणा कर सकते हैं, और शरीर का पोषण हो जाता है, और प्रकृत है ये। लेकिन अलग जो मनोदोष में, जो माइंड में जो दोष उत्पन्न होते हैं कि तम का गुण बढ़ता है तो भी निद्रा आती है। हमारे आयुर्वेद में निद्रा का वर्णन है। और कफ प्रकोप ज्यादा होता है तो उससे भी निद्रा है। और मन और शरीर को थकान जब आती है तो निद्रा आती है। और व्याधियों के उपद्रव स्वरूप निद्रा आती है। और 6th जो है, ये जो आज का जो वेबिनार हम करने जा रहे हैं, तो कोविड-19 पेंडेमिक, तो ये वायरस का जब मनोदोष में वायरस का जब ये होता है, प्रवेश हो जाता है, तो उसी के कारण भी निद्रा आ सकती है। तो इसका दोनों का जो ये है विस्तृत आपको आज के ये वेबिनार में इसका जो लेक्चर में आपको ये फीस मिलने वाली है। बाद में ये मज्जावस्रोतस का व्याधि है। ये ऐसा एक विशेष है कि वो भी मज्जावस्रोतस का व्याधि है और ये भी मज्जावस्रोतस का व्याधि है। तो इसमें मूल स्थान में फिर से मैं जो बताया कि मज्जावस्रोतस है, वो उसका जो मूल स्थान है, तो उधर आप एग्जामिनेशन पेशेंट का करते समय आप ध्यान देना चाहिए। अच्छी तरह से पेशेंट को एग्जामिनेशन करके डिसाइड करना चाहिए कि कौन सा पंचकर्म कर सकते हैं। तो once again I welcome you all in this national webinar organized by our PG department of Panchakarma. Thank you very much.
Thank you, sir. Now I would like to request Professor Sanjeev Sharma sir, our beloved director, to deliver inaugural speech.
Thank you, Dr. Krishna, and good morning to all. Professor Surendra V. Pathak ji, Head of the Department Panchakarma, National Institute of Ayurveda, deemed to be University. Our experts, resource persons for the eminent personalities in the field, Dr. Murlidhar Pujar, Dr. Shibu Varghese, my fellow colleagues, Dr. Gopesh Mangal ji, Dr. Sarvesh ji, Dr. Kshipra, Vaidya Bapat ji, Tamar ji, our PG and PhD scholars, and all the delegates from the country and abroad who are viewing this webinar through various social media platforms and various channels. First of all, I, on behalf of the institute, which has recently been notified as the deemed to be university, extend a heartiest warm welcome on this platform. My congratulations and thanks to the Panchakarma department for conceiving the idea of organizing a webinar on the welfare of the faculty, the students, and ultimately for the welfare of the society. Really, this is a wonderful time and wonderful event, and that event is aligned with the 5th Ayurveda Day. As we know that Ministry of Ayush is celebrating 5th Ayurveda Day, and different activities pre-Ayurveda Day and post-Ayurveda Day are being celebrated countrywide by different organizations, and this event is also one of them. I am really very much excited and happy that the topics which have been chosen for the discussion here, those are very relevant topics, and they are required to be discussed at large in different platforms, both the spinal disorders and sleep disorders. Both are in huge number in the clinical practice. If we talk about the spinal disorders, the different types of the spinal disorders may be degenerative, or maybe metabolic, or maybe infective, or maybe traumatic, or some other kinds of spinal disorders. Definitely they are hampering the life of a person. They are hampering the day-to-day activities of a person. And the reason, most of the time, the reason is the hectic lifestyle, or faulty lifestyle, or some other reasons. And the Panchakarma, we in Ayurveda are having Panchakarma within our inventory of the various interventions. And by using the various Panchakarma modalities, we can definitely work on this issue, and we can alleviate the symptoms or diseases of the suffering society. And really, this is the requirement, because when we see the clinical scenario, then the spinal disorders are much common. And I think almost 85 to 90% people, they suffer from some kind of back problem or some kind of spine problem, right from the cervical spine or lumbar spine most of the time, and then sometimes in the dorsal spine, etc. And spine disorders, they include so many components, so I don't want to go into the details of everything, but really the topic is very much relevant, and I hope the deliberations will be there on this topic will be very much useful for our faculty and our students, and we shall be enlightened by the thoughts of our experts. Similarly, sleep disorders are again very common nowadays in the society. Again, the reason may be because for the disturbance in sleep, the reasons may be intrinsic or extrinsic, and plenty of sleep disorders now we are seeing. Maybe it's in simple insomnia, it may be regular insomnia, it may be some other kind of sleep disorders which need to be rectified, to be managed effectively. And the sleep is very important factor for immunity also. When we talk about the Trayopastambha in Ayurveda, Ahar, Nidra, and Brahmacharya, Nidra is very useful component, but at the same time it is least discussed at various platforms globally, because we are focusing on Ahara, food. Although the discussions on food are also very much relevant, and there should be, and there is much focus on food worldwide. But so far as the Nidra or sleep is concerned, people are comparatively discussing it at lesser level. But this needs to be addressed, because sleep disorders, if somebody is having sleep disorder and he is not having good sleep as per his own schedule he should have, it may range from 6 to 8 hours. But if he is not having appropriate sleep at night time or at appropriate time, that he may face so many problems during daytime, during his activities, and his vigor, his concentration, his memory, and his energy, and overall health is disturbed. So sleep disorders are really to be addressed, and we through Panchakarma and through counseling and through other medications, we can address sleep disorders, because most of the time the sleep disorders, they don't need any intervention except counseling and assurance of the patient that how he should manage his lifestyle. And most of the time the sleep disorders are stress induced. So addressing all these things, and some here that the role of Panchakarma is very important when there are regular sleep disorders, and we definitely can help the ailing society. So both the topics are very relevant, and I congratulate the department for choosing these very important topics. And my Best wishes to the department for the success of this today's webinar, and I hope this will be most successful event and it will enrich all of us who are participating in this event. Thank you very much. Thank you, Department of Panchakarma. Thank you, our experts, and thanks to all the participants who are delegates who are participating in this event. Thank you.
Thank you very much, sir. With your kind permission, I would like to initiate the first session. The session coordinator of this session is Dr. Sarvesh Kumar Singh, Assistant Professor, PG Department of Panchakarma, NIE. Handing over the platform to you, sir.
Thank you very much, madam. Good morning, everyone. The eminent speaker of this session is Dr. Shibu Varghese, sir. He has from a traditional Ayurvedic background located in Mangalam. He has completed his post-graduation in Panchakarma. Presently, he is working as hospital superintendent and HOD Panchakarma at Nangeli Ayurvedic College and simultaneously handling the office as managing director at Kalarikal Hospital. Dr. Varghese is a renowned practitioner and teacher. Clinical medicine and radiology are his area of expertise. He is founder and secretary of PACTO organization and joint secretary of AMEI Ernakulam. I am handing over the session to Dr. Shibu Varghese, sir. Thank you. Dr. Shibu Varghese, sir.
Good morning, sir.
Varghese, sir.
Good morning. It's a great privilege for me to take a class at NIA, the most prestigious institution of Ayurveda in India. First of all, I'd like to thank the director of NIA and my favorite teacher, Dr. Surendra Vedpatak sir, for giving me such an opportunity to present a class at NIA. So, can I share my slide now? Hello?
Yes, Dr. Shibu. Yes, Dr. Shibu, you are audible.
Can I share my slide now? Can I go ahead with the presentation?
Yes.
ഇത് എന്റെ സ്ക്രീനിൽ ഇടാൻ വന്നേ ഇതാ മതിയോ അയ്യോ Did my presentation appear in the screen? Hello?
Sir, your presentation is not, we are not able to see your presentation slides.
Not able to see. 1 minute, just share it.
I think, sir, your video is off.
Video is off. Okay. On. No, it's full window എടുക്കുക എന്റെ സ്ക്രീൻ എടുക്കാം സാറേ ഇന്നലെ എല്ലാം എടുത്തേ ഇനി ഇതിൽ ക്ലിക്ക് ചെയ്തിട്ട് വേണം തോന്നുന്നു അല്ലേ Did my presentation appear?
No, it's not visible. Yes,
Okay, sir.
it is visible.
Is it visible now? Okay.
Now it is visible, sir.
Okay. So can I go ahead with the presentation?
Yeah.
Okay. It's a very warm good morning to all. So today the topic for my presentation is radiological diagnosis of spine disorders and its Panchakarma with a special reference to Ashtavedya practices. Rogamadav Parikshade Tadanandram Aushadam. This slogan emphasizes the importance of diagnosis in clinical practice. Though in our Panchakarma clinics, we treat based on Ayurveda principles only, but still in the present era of clinical practice, it is very important to diagnose a disease using the advanced imaging and biochemical investigations. Among the diseases we treat in Panchakarma, the musculoskeletal diseases are the prime one. Especially in that spine disorder, the most important one which we get in the clinics. So it is very important to diagnose the particular disease based on the new investigational tools. Otherwise, we may land up in a lot of problems. Suppose if a patient comes with a low backache, instead of going away straight with the cardiopathy, we need to diagnose because it could be a simple in a degenerative condition, it could be inflammatory arthritis, it could be an infective lesion, or it could be a malignant lesion. But our investigational tools are very important to diagnose what disease exactly it is. Otherwise, I had seen patients who are coming from many prestigious Ayurvedic institutions having POTS paraplegia because they did Abhyanga, etc., with diagnosing it as a case of POTS pain. So it should not happen from our people. So my humble attempt today is to make sure that we diagnose the low spine disorders properly from the imaging studies and how to interpret that in our clinical practice and how we can incorporate the Panchakarma into the diagnosis we made through the imaging studies. So this is William Conrad Röntgen. He is considered as the father of diagnostic radiology. He has invented this X-rays in 1895 and he got the first Nobel Prize in physics in 1901. Actually, his invention was an accidental invention when he was trying to investigate different types of vacuum tubes. On a vacuum tube, he has kept an aluminum window, and when he put on the vacuum tube, he found a shimmering effect on a board painted with the barium cyanide kept near to this vacuum tube. So he found that this shimmering effect is mainly because of some invisible rays which can penetrate through harder substances. And he has designated it as X-rays using the mathematical denomination of something which is unknown. So after this invention, many people have come to saying that we want the patent of this invention. But William Conrad Röntgen, being a very noble man, he wanted the whole of the mankind, including Ayurvedians, to use this invention for diagnostic purpose. So, and he refused to take money from the money as patent. So the first X-ray, that is the first X-ray ever taken in the history. That X-ray demonstrates the hand of his wife, Anna Bertrandgen. The second X-ray is an X-ray he has taken to demonstrate in a public function. So after taking this X-ray, Röntgen became very much excited to see the wedding ring on her wife's hand. But unfortunately, that excitement didn't last long because she got divorced after some time. So before venturing into the intricacies of such an intriguing subject of radiology, it would be better to understand the basics of spine radiology. So the key concept of spine radiology, the X-ray film before taking an X-ray is white or transparent in color. That means if you keep on an X-ray V-box, it appears as white in color. When X-rays fall on the film, it darkens it. This is a very key concept of radiology. So normally before taking the X-ray film will be white in color, and when X-rays fall on the film, it darkens it. This is a very key concept of radiology. Next concept. So basically there are 5 radiological densities. So now you can see a tumbler. In the tumbler, we have put water, we have put some Tikta Ngrida, a key and a piece of bone. Now you can differentiate these structures because it is because of the different densities these structure possess. So there are basically 5 radiological densities. They are in the order of increasing brightness: air, fat, fluid, bone, and metal. You can see the first one, that is the air density. The second is Tikthangritam, that is the fat density. And third is water fluid density. 4 is bone, and 5th is metal. So the different structures can be identified in the X-ray based on the different densities these structures possess. So you'll get the idea clear why I'm seeing the chest X-ray. The chest X-ray, you can see the lungs appear black in color because that is an air density. You can see the breast shadow little more whiter because that is a fat density. You can the heart, which is more brighter because that's a water density because it is composed of blood. And you can see the bone because it is composed of calcium, which is more density. And you can see the safety pin over there. It is more brighter because that's a metal density. So these different structures can be identified in the X-ray mainly because of the difference in the densities these structure possess. So this is again a key concept of radiology. It need to be understood. So next, whenever you get an X-ray in your hand, first you make sure that the X-ray belongs to the same patient. So normally when a patient comes to a clinic, they may carry the X-rays of their husband, wife, children, etc. So make sure that whenever you get an X-ray in your hand, make sure that that X-ray belongs to the same patient. So you need to see the name of the patient in that X-ray, the age of the patient, and left and right. This is a basic primary thing you should be careful before reading an X-ray, because you make a very proper, you may be a good radiologist, you make a proper diagnosis in a wrong patient, it's very much embarrassing. So make sure it belongs to the same patient. And 2 problems we face in the clinical practice is, one is overexposed and second is underexposed. Overexposed means so more number of X-rays has fallen on the underexposed means less number of X-rays has fallen on the film, and overexposed means more number of X-rays fallen on the film. The first, you can see it is an underexposed X-ray where you can see the different densities could not be made out clearly. On the second, in overexposed, you can't make out the fluid density and the fat density. So these are the 2 complications which arises when you get an X-ray in the clinical practice. Always, if you get an underexposed X-ray or an overexposed X-ray, send the X-ray back to the X-ray center saying that it is not a properly exposed X-ray. Next is radiology of the cervical spine. So the cervical spine X-ray, before taking a spine X-ray, we should decide which projection X-ray need to be taken, whether it should be an anterior posterior or a posterior anterior. So I'll tell you one example. So before taking an X-ray, which view has to be taken depending upon the location of that particular structure. If you want to take a chest X-ray, we depend upon an posterior anterior view. The reason is that the heart and big blood vessels lies anteriorly. So how much near the structures to the film, that much clarity will be there in the X-ray. So if you want to take a chest X-ray, it should be PA view. But in case of spine X-ray, it has to be an anterior posterior view because the vertebra is situated in the posterior aspect of the body. So we will be standing close to the X-ray view box and X-ray will be taken. So what will happen? The spine will be very close to the X-ray film. We will get a very clear X-ray. So this is how an anterior posterior X-ray of cervical spine is taken. Here the central beam will be directed at the level of the thyroid cartilage in the C5 level. This is how an anterior posterior X-ray is taken. So this is an anterior posterior X-ray. Next is the lateral projection. In the lateral projection, the beam will be laterally placed in the level of the thyroid cartilage below the mastoid process at the level of C5 vertebra. Next is a Simmer's view. Usually the lower thoracic spine and lower cervical spine and upper thoracic spine and cervico-thoracic junction is liable for too many traumatic injuries. So usually when you take a lateral X-ray, the lower the cervico-thoracic junction will be disrupted or obliterated by the shoulder shadow. So to get a clear view of the cervico-thoracic junction and upper thoracic spine, we should go for a Simmer's view. In the Simmer's view, one hand will be abducted and X-ray is taken, and the central beam will be directed just above the shoulder. This is how a swimmer's view X-ray is taken. You can see the swimmer's view here. The C7 and T1 and T2 is clearly seen. If you suspect a traumatic injury at the C7 or T1, always go for a swimmer's view X-ray. Next is an oblique view X-ray. The oblique view X-ray is very similar to that of the lateral X-ray, but here oblique view is usually preferred when you suspect a radiculopathy. That means pain in the neck radiating to right or left hand. When you take an X-ray in oblique view, you have to always specify that whether it is a right oblique or a left oblique. If the pain is radiating to the right hand, the X-ray has to be right oblique. If the pain is radiating to the left hand, it has to be left oblique. This is an oblique view X-ray. Next is anterior posterior open mouth view or an odontoid view. As far as we Ayurvedic doctors are concerned, this view is very important because AP open mouth view is mainly to study about the first and second cervical vertebrae. That means the atlas and axis. In rheumatoid arthritis, usually disassociation of atlas and axis is very common. So to study about the alignment of the atlas and axis, we need to go for the anterior posterior open mouth view. But one practical difficulty we face in the clinics is that if you want to do here, the central beam is directed just below the incisor teeth. But if you want to get a proper exposed X-ray, the mouth has to be wide open. But by the time of severe rheumatoid arthritis, this temporomandibular arthritis also will be set in. So patient will not be able to open the mouth completely. It affects the precision of the X-rays. This is an atlas. This is an axis. You can see the dens or the odontoid process clearly. So this is an odontoid view X-ray. Here you can see the dens, the C2 vertebral body. This is the lateral body of C1 and this is the lateral body of C1. This is an odontoid view. Next is hyperflexion and hyperextension view. This is mainly taken to diagnose whiplash injuries, especially sudden accidents in the motor to find out whether there is a soft tissue injury or not. In hyperflexion, the patient need to hyperflex the neck, and the hyperextension patient need to hyperextend the neck. It has to be voluntarily done by the patient. The technician should not flex or extend the neck. This is a hyperflexion view, hyperextension, mainly to rule out other traumatic injuries, and just to diagnose a whiplash injuries, we go for the hyperflexion as well as hyperextension views. So, am I clearly audible, sir? Am I clearly audible? Next is interpretation.
हाँ सर, आवाज आ रही है आपकी?
It's clear, no? It's clear, no?
Yeah.
Okay, fine. No. Next is interpretation of the X-rays. Whenever you get an X-ray in your hand, so normally what you do, we just study the vertebral body and the intervertebral disc. It is not the proper way to interpret an X-ray. Whenever you get an X-ray in your hand, we should interpret the X-ray sequentially in adequacy, alignment, bone, cartilage, disc, and soft tissue. So we need to sequentially evaluate these things in terms of adequacy, alignment, bone, cartilage, disc, and soft tissue. Otherwise, you are likely to miss many diagnoses. First is adequacy. What do you mean by an adequate cervical X-ray? In an adequate cervical X-ray, there should be all seven cervical vertebrae should be visible. Cervicothoracic junction also should be seen. And you should have a proper bony density and soft tissue density. Here you can see 7 cervical vertebrae are seen. Cervicothoracic junction is seen. The soft tissues, the thyroid cartilage, the trachea, and soft tissues are clearly seen. So this X-ray, we call it an adequate X-ray. First, analyze whether the X-ray is adequate or not. So this is an inadequate X-ray. Here in this X-ray, you can see only 1, 2, 3, only 3 cervical vertebrae. In the second X-ray, you can see only 4 cervical vertebrae. So this is an inadequate X-ray. If you get an inadequate X-ray like this, send the patient back to the X-ray center, say that this is an inadequate X-ray. We need a properly adequate X-ray for the diagnosis. Next thing, after looking into the adequacy, we look into the alignment of the X-ray. So to look the alignment, we should draw 4 imaginary lines. you should draw 4 imaginary. One is the anterior vertebral line, posterior vertebral line, spinolamellar line, and spinous process line. These are the 4 imaginary lines you should draw to assess the alignment of the spine. So anterior vertebral line is in front of the anterior vertebral body. Posterior vertebral line is in posterior to the posterior vertebral body. Spinolamellar line is the posterior part of the vertebral column, and spinous process line is in the tip of the spinous process. This is how we need to, among that, the second line, that is the posterior vertebral line, is the best line to assess the alignment, because that is least disrupted by the osteophytic deposition. That's about the alignment. So here you can see in this X-ray, when you draw a 4 imaginary, you can find a step deformity. It indicates a unilateral facetal dislocation. So always draw 4 imaginary lines, otherwise you are likely to miss a mild listhesis. Next is bony landmass. After adequacy and alignment, let's look into the bony landmass. So your eye should follow the uninterrupted cortical margin of all vertebral bodies, including the dens. Your eye should follow the uninterrupted cortical margins of all vertebral bodies. The vertebral body should be rectangular in shape and roughly equal in size, though the size of C3 and C4 is slightly smaller than C3 and C6. That is the normal anatomy. Also, the anterior height should roughly equal posterior height. It should be roughly, but here you can see the anterior height is little lesser than posterior. That is 3 millimeter height will be lesser in the anterior part of the vertebral body compared to the posterior height. That is one bony landmark which you need to find. But your eye should follow each and every vertebral body's margin. That's very important. Next bony landmark is the pedicle. You can see the bluish color. This is the pedicle. The pedicle supports the articular pillars. Pedicle supports the articular pillars. Always look into the pedicle, because in osteolytic tumors and infective pathology, first affected part will be the pedicle. So always look into the pedicle whenever you get an X-ray in your hand. Second is the spinous process. The size of the spinous process goes on increasing as you come down. You can see the biggest is C7, the C5, C6 is little smaller, C5 is again smaller. So that's the spinous process. Next is the lamina. Lamina is not very distinctly seen on the X-ray. Next is facetal joints, the superior articulating facet and inferior articulating facet. It is very important to look into the facetal joints, because facetal hypertrophy can lead to exit foramen narrowing. That means radiculopathy could be there because of the facetal joint arthropathy. So look into the facets when you get an X-ray in your hand. Next is a lateral mass. The lateral mass appears as a rhomboid shaped structure projecting downwards and backwards. That is lateral mass. Second is the double cortical line. This double cortical line is not it results from a slight obliquity from the lateral position. When you take an X-ray, if the lateral beam is slightly becomes oblique, it results in double cortical line. This is not a fracture. Many a times students ask me, is it a fracture? It's not a fracture. This double cortical lines arises because of a slight obliquity from the lateral projection. Next is cartilaginous space. You need to look into the cartilaginous space. There's a space called predental space, the space between the dens of the C2 and the C1 vertebral body. This is the predental space. The predental space should be 3 millimeter in adults and 5 millimeter in children. So if it is more than 3 millimeter, especially after the trauma, if a patient comes, if the cartilaginous space is more than 3 millimeter, it indicates a fracture of the odontoid process or a disruption of the transverse ligament likely. That is about the predental space. Next is the disc space. You are all aware of disc space. You all know your masters in how to analyze the disc space. You can see the anterior part of the disc space and posterior part of the disc space should be analyzed. This is the disc space. There's the soft tissue space. Whenever you get an X-ray in your hand, you usually look into the bony structures only. But that is not the proper way to analyze an X-ray. Always, you should look into the soft tissue, especially if a patient presents with a traumatic injury. Many a times, the fracture may be very subtle that you may not be able to make out the fracture line from the X-ray. So in such condition, this soft tissue space gives us a clue about a occult fracture. That means whenever there's an occult fracture, there'll be some blood or hematoma will be formed in front of the vertebral bodies. The hematoma causes an increased soft tissue space. So first soft tissue space, nasopharyngeal space. Nasopharyngeal space is the space in front of the first cervical vertebral body. If there is a fracture of the first cervical vertebral body, there will the nasopharyngeal space, which is normally is 10 millimeter, it will be increased. Second is the retropharyngeal space, some C2 to C4. This much of area is the retropharyngeal space. So if there is a fracture of a C2, C3 or C4, the retropharyngeal space, normally the retropharyngeal soft tissue is 5 to 7 millimeter. It will be increased if there is a fracture of C2, C3 or C4. Next is retrotracheal space. The retrotracheal space is 22 millimeter. If there is a fracture of the C4 or C5, what will happen? C5 or C5 vertebra, the retrotracheal space, which is 22 millimeter, will be increased. So in clinical practice, if you are encountering a trauma cases, you always look into the soft tissue spaces. In non-traumatic complaints, it is not that important, but in traumatic injuries, you should look into the soft tissue space. If the soft tissue space is increased, send the patient for a CT scan. So here you can see the retrotracheal space is increased. Instead of 5 to 7 millimeter, it has gone more than 30 millimeters. So you can suspect a fracture of the C2 vertebral body. If you look very clearly, you can see a fracture line. Fanning of this can be seen. So this soft tissue itself gives a clue about a focal fracture of the C2 vertebral body. Next is how to interpret an AP view. Suppose you got an AP view X-ray in the hand. What all things should be analyzed when you get an AP view X-ray in your hand? First, look into the lateral mass. You can see the lateral mass. The lateral mass appears as undulated margins. You can see the undulated margin. That means wave-like margins. This is a wave-like margins. It's a smooth wave-like margin. So if there is a fracture of the lateral mass, that can be seen on the AP view X-ray. Next is the spinous process. The spinous process will be at the midline. If the spinous process is aligned left or right, it indicates a unilateral facetal dislocation. And the interspinous distance, that means the distance from the one spine to the other, the distance from one spine to the other should be symmetric. If the interspinous distance is 1.5 times more or less, it indicates a unilateral facetal dislocation. So spinous process should be in the midline, and the interspinous distance should be symmetric throughout. Third thing you need to look into is the vertebral body height. The vertebral body height. If there is a compression fracture, that can be analyzed from the vertebral body height in the AP view. And fourth is the intervertebral disc space. If there is intervertebral disc space is reduced, that also can be made out from the AP view X-ray. So I repeat, the four things need to be analyzed in the AP view of the cervical spine. One is the lateral mass, the spinous process, the vertebral body, and the intervertebral disc space. So you should not miss the diagnosis of these four structures from an anterior posterior AP view. So usually we prefer AP view to analyze a cervical pain or a pain radiating from the neck to the shoulder. So you can always, when you prescribe an X-ray, you can write APV with the right shoulder or left shoulder. So within a single X-ray, you can make out the pathology of the cervical spine as well as the shoulder. So no need to go for two X-rays. If you doubt whether it is a pathology from the shoulder or if it is a pathology from the cervical spine, you can write APV X-ray with the right or left shoulder, which is relevant. This will be helpful in your clinical practice. Next is the lateral view X-ray. Among the views, the lateral view is the most important view, or it gives the maximum information about the cervical spine. Here you can see the superior as well as the inferior occipital condyles, the posterior arch, the vertebral bodies from C1 to C7 and cervicothoracic junction will be seen. Then you can see the intervertebral disc space. You can see the superior as well as inferior articulating facets. The lamina can be seen. Spinous process can be seen. So all the maximum information of the cervical spine will be obtained from the lateral view X-ray. Suppose if a patient presents with a myelopathy, it is always better to go for a lateral view X-ray. That means you suspect a central spinal cord is compressed and it is causing a myelopathy. It is better to go for a lateral view X-ray. Next is the oblique view. Oblique view is preferred when you suspect a radiculopathy. Suppose if you feel a pain in the neck radiating to the hands, it is better to go for an oblique view than a lateral view, because the intervertebral foramen is clearly seen. The intervertebral foramen is clearly seen. If there is a narrowing of the intervertebral foramina, suppose if C4, C4, C5 is narrowed, then it's very evident that there could be a C5 radiculopathy. So oblique view is preferred in such condition. Also, if you want to analyze the pediculin profile following a traumatic injury, if you suspect a pedicular fracture or an articular process fracture, if you suspect a pedicular or articular process fracture, it is oblique view is a preferred view than CT or MRI. And oblique view, as prescribed, you have to always mention right oblique or left oblique. If pain is radiating from the right, from the neck to the right hand, right oblique. If to the left hand, it has to be left oblique. Next is the odontoid view. The odontoid view, what you can see is that it is mainly used to find out traumatic injury and in rheumatoid arthritis. If to analyze the relationship between the C1 and C2 vertebral body. Here you can see in odontoid view, the odontoid view should have a proper dense, or there should be uninterrupted cortical margins of the C2 vertebral body with the dens. So uninterrupted, if there's a fracture line here, then we can make sure that it's a fracture of the dens. Then the distance from the dens to the lateral masses, you can see this, the distance from the dens to the lateral masses, it should be symmetric. If the distance between the dens to the lateral mass increase more, then we have to suspect a fracture of the ring of C1. Also, the outer border of C1 and C2 should be in the same line. So, three things. One is the outer border of C1 and C2 should be in the same line. If C1 is more laterally seen, then it indicates a fracture of C1. Also, the distance from the C1 to the dens should be symmetric. If it is increased, then it indicates the fracture of the C1 ring or a disruption of the transverse ligament. This is how you need to look into the odontoid view. Next is trauma types. Whenever we sit in the interior clinics, etc., it is very important to understand how to read the X-ray of the in trauma. So mainly there are three types of trauma which happens in the clinical practice. One is the Jefferson fracture, which refers to the axial pressure. That means something falls on the head, or while walking with a load on the head, if the axial pressure comes on the spine, it causes a fracture called the Jefferson fracture. And next is teardrop fracture, which occurs due to hyperflexion injury, and hangman's fracture, especially in a motor vehicle accident and while attempt to hang, there will be hyperextension injury. So three types of injury. One is the axial pressure on the spine, second is the hyperflexion injury, and third is the hyperextension injury, which is called as a hangman's fracture. So here you can see the Jefferson fracture, that means the odontoid view. In Jefferson fracture, what has happened? So I told you the outer border of the C1 and the C2 should be in the same line. Here you can see the C1 is laterally displaced. Also, the distance from the dens to the C1 is increased here. So it is called, there is a compression fracture of the bony ring of C1. This is called as Jefferson fracture. It's a very unstable injury. You are less likely to, and the patient will be having a quadriplegia in such condition. Next is hangman's fracture. Hangman's fracture, it occurs more in road traffic accidents, because when the head hits the dashboard, it is a hyperextension injury. Hyperextension injury, what will happen? Here you can see there is a slippage of the C2 vertebra, or there is a anterior listhesis of the C2 vertebral body. There's a fanning of the spine. You can see a fracture line here. And prevertebral soft tissue space, instead of 5 to 7, it has gone up to 20 or 25. So this is a hangman's fracture. Next, a teardrop fracture. It is a hyperflexion injury, especially when children dive into a shallow water, or any hyperflexion injury leads to a compression fracture of the cervical, and there will be a teardrop segment will be avulsed. It is a hyperflexion injury, teardrop fracture. Next is unilateral facetal dislocation. This unilateral facetal dislocation generally occurs when we rotate the neck in a flexed position. It happens from the Ayurvedic hospitals or Ayurveda clinics or unauthorized treatment centers or massage centers. Normally, there's a practice after a neck abhinga, they do a rotation of the neck in the flex position, right and left, and a click sound comes, and patient will be happy and the therapist will be happy. But it may lead to a unilateral faceted dislocation. Such practices should be if someone is running a spa, someone is having a hospital with a culinary treatment, etc. Never advise the therapist to go for a lateral rotation of the neck in the flexed portion because there will be a unilateral facetal dislocation. Here I can see less than 25% of this vertebra is slip different compared to the lower vertebra. If less than 50% of the vertebra is slip different, we call it a unilateral facetal dislocation and fanning of the spinous process. So should never laterally rotate the neck during any Ayurvedic Purvakarma procedure. Next is bilateral facetal dislocation. It generally happens because of a sudden hyperflexion injury. More than 50% of the vertebrae is slip different. That is called as bilateral facetal dislocation. You can see this is a bilateral facetal dislocation. More than 50% of the vertebrae has been slip different. Next is cervical kyphosis. As you know, the cervical spine has got a lordotic curve. This is a normal lordotic curve. And the thoracic spine has got a kyphotic curve. And lumbar spine has got a lordotic curve. In certain pathologies, the cervical lordosis will be lost. That is called a cervical kyphosis, or we generally call it a military neck. It can happen because of many reasons. One is if there is a collapse of the disc. As we age, there is the wear and tear of the disc. If the disc collapse, what will happen? The head will twist forward and it pushes the neck to backwards and causes a straightening of the spine. Second is a congenital defect. There is a condition called block vertebra. Block vertebra means there is a fusion of two vertebrae. So there will not be intervertebral disc in between. Two vertebrae will be fused. That's a congenital defect. It generally comes in the clinic. In such condition, also the cervical spine will be straight. And if there is a compression fracture, if the anterior part of the vertebral body gets tipped or it gets the reduced anterior posterior diameter, then also it can result in cervical kyphosis. And as an iatrogenic causes after patient after any laminectomy, also it may result in cervical kyphosis. Also, patient with the ankylosing spondylitis, seronegative spondyloarthropathies, patient may have a straightened spine. It also happens whenever happens whenever there is a severe spasm of the cervical spine. Suppose if you are having a cervical intervertebral disc prolapse, severe spasm of the paraspine muscles of the cervical spine causes the spine to be straightened. In such condition, give adequate nadi swedam because wet moist heat relieves the spasm. A mild abhinga nadi swedam, if it is because spasmodic kyphosis, it will be relieved. This is your favorite topic, that's a cervical spondylosis. In this X-ray, you can see the C4, C5 and C5, C6 disc space has been reduced. Anterior osteophyte lippings. So it is very evident that it is a case of a cervical spondylosis. The bone mineral density is also reduced. Here you can see spur of the bone, the narrowing of the intervertebral disc space. Here also you can see. So it is a case of cervical spondylosis. You are maybe aware. So normally, if it is a cervical spondylosis, how do you approach in the clinic in Panchakarma? So normally, cervical spondylosis presents as a Vata Kafahara avastha projecting a Nirama condition. In such condition, our treatment line should be mainly based on Vata Kafahara Chilsa, Shulahara Chilsa, Asthik Shayajanya Chilsa, and Nadi Bilya Chilsa. Because four things. One is the Vata Kafahara and Shulahara, because the pain will be there. Then there will be severe degeneration of the bone. So it has to be Asthik Shayajanya Chikilsa, and sometimes nerve will be entrapped in that. So Nadi Bilya Chikilsa has to be followed. So in such conditions, Snehana, Swedana, Snehabasti, Kshirabasti, and Nasya is the treatment which is generally advocated in such condition. As Snehana and Swedana, we can go for Patra Podali Sweda because Patra Podali Sweda is Vada Kafahara and Shulahara. So initial first line of treatment, you can go for Patra Podali Sweda. Even Grievobasti is ideal, but one problem with the Grievobasti is if you want to do a Grievobasti, the doctor has to treat the patient. I won't never encourage my therapist to do a Grievobasti, because while doing a Grievobasti, if the patient's neck is kept in a slightly hyperflexed or hyperextended condition, it again reduces the anterior posterior diameter of the spinal canal and exit foramen and aggravates the condition. If you are doing it yourself, if you can keep the neck in a very normal position and do the grievous, it is well and good. Otherwise, I do prefer Elekiri as Vada Kafahara Chilsa and Shulahara Chilsa. And later we can go for Nasya, Brahmana Nasya, because Nasya is indicated to give strength to the Griva and Bahu Susuda, 50th chapter, 41st slogan is clearly mentioned. So, Brahmana Nasya with Shirabala, Dhanundran Taila, Karpasastyadi Taila, Anu Taila, and Kunkumadi Taila can be used as Nasya in case of severe cervical spondylosis. Also, Astik Shayajani Chilsa, Brahmana Chilsa, Sneha Basti as Matra Basti. Matra Basti with Dhanundran Taila, or if neurological presentations are there, then Sahajradi Taila or Tiktaga Girda. Panchatikta Gugulu Grada Snehavan also can be given, because Panchatikta because Shira Basti or Tikta Bastis are indicated in Asti Majjagada Vigaras. You can even go for Gudushya the Shira Basti also, because Tikta Bastis are indicated for Asti Majjagada Vigaras. And finally, for Nadi Billi also, if you wish to go for, you can go for a Shashtika Shali also. This is how we generally manage a case of cervical spondylosis. Also, traction is found to be very good in managing cervical spondylosis, because traction, there are three types of traction. One is a continuous traction, where you can put up to 1/10 of the body weight, 1/7 or 1/10, up to 4 to 7 kgs can be given continuously, or static traction. Here in static traction, up to 5 to 14 kgs can be put for a matter of 20 minutes. Then intermittent traction with the help of a machine. But when you give a traction, it is better to have in the supine position than in the sitting position, because in cervical spondylosis, especially with the radiculopathies, the traction gives a tremendous result along with our Snehana and Swedana and Basti treatment. Next is rheumatoid arthritis. As you know, normally when a patient have a rheumatoid arthritis, usually starts in the metacarpophalangeal joints. So along with the involvement of metacarpophalangeal joint, the second most common area which is affected with the rheumatoid arthritis is the atlantoaxial joint. The first and second cervical vertebrae is affected with the rheumatoid arthritis. So whenever you take an X-ray, that's why I told the Ottendorf process is very important. Here in this X-ray, you can see there's a fusion of first and second cervical vertebra, severe osteopenia, the disc and end plates are eroded, then the alignment is completely lost. It gives to a diagnosis of an inflammatory arthritis, most probably a rheumatoid arthritis. Here also you can see first and second cervical vertebra is fused. Then you can see there is a erosion at the joint margin, bone mineral density is lost, complete alignment of the bone is lost. It leads to the diagnosis of a rheumatoid arthritis. If it's a rheumatoid arthritis, generally I follow, as you know, it can be correlated with the Amavada. Amahara treatment has to be followed. I generally in the clinic practices Agni Leba, one which used to be practiced in my mother institution for 7 days. Agni Leba contains, as you know, 5 wet drugs and 5 dry drugs, and a paste is applied to the body, which is kept from morning to next morning. That is the Agni Leba Chilsa. And one more thing which usually does in Kerala after the Agni Leba, I generally go for a Dhanyamla Dana. Dhanyamla Dana is a sour liquid made up from these medicines. I can share this slide. The slide has been already shared to NIA. So who wish to have this, they can copy from NIA. Then after the Dhanyamla Dara, then Erandamula Sharabasti is administered. 3 Erandamula Sharabasti is present. This is the general Panchakarma procedure which I generally do for a patient with the rheumatoid arthritis. Next is the spinal canal stenosis. Excuse me, am I clearly audible? Is there anything in between? Is there any suggestions to say? Excuse me. Am I clearly audible now also?
Yes, sir.
Yes, okay. Next is the spinal canal stenosis. In spinal canals, the plain X-ray has got very limited role in analyzing a spinal canal stenosis. But if there is a osteophytes encroaching into the vertebral canals, here in this X-ray you can see the vertebral foramen has been completely narrowed because of the osteophytes. So this can be clearly made out from the X-ray, especially if you go for an oblique X-ray, the spinal canal stenosis can be made out. So if a patient with the central canal stenosis, that means myelopathy, usually myelopathy occurs because of the bulged disc or a hypertrophy of the ligament flavum or a osteophytes encroaching into the spinal canal. If it is a central canal stenosis, go for the lateral view. If it's a exit foramen stenosis, that will say lateral canal stenosis, that means pain radiating from the hand, neck to the hands, go for a oblique view. This is an oblique view where you can clearly see the narrowing of the intervertebral foramina. So normally a patient with the spinal canal stenosis will exhibit Kaphavrta Vada Lakshana. Now, this is a picture you can see. This is a central canal stenosis. Here, the intervertebral disc and osteophytes are compressed the spinal canal. So, from the plain X-ray, you can calculate the spinal canal stenosis. Use a torque ratio. That means the ratio of the vertebral, the distance of the vertebral body with the divided by the distance of the vertebral canal. But practically, that is not very possible nowadays. MRI has come in, so MRI has replaced this torque calculation, etc. But from the X-ray, if you can see if the osteophytes are encroached into the vertebral canal, this could be very well made. So in the spinal canal stenosis, if you look into the present clinical presentation, generally gives to a presentation of a Kaphavrta Vada with the Sama condition. In such condition, always go for Rukshana Chikitsa with Tikshana Bastis. That's the first line of treatment should be adopted in spinal canal stenosis. If the patient has got a Kaphavrta Vada Lakshana. Normally, I start with the Tikshana Basti, a Vaidarna Basti, later followed by a Churna Pindasweda. Churna Pindasweda with the Kottanjukadi. In Kerala, generally we use Kottanjukadi Churna, Churna Pindasweda, especially in patients with the Kaphavrta Vada. 5 to 7 days of Churna Pindasweda is done. That is a pure Ruksha Sweda. Along with that, a course of Vaidarna Basti is also done. A course of Vaidarna Basti is also done in case of Kaphavrta Vada. Later, after that, I go for Jambira Pindasweda, which is slightly Ruksha Snigdha Sweda. And finally, Belamula Niruhabasti. Why I prefer Belamula Niruhabasti is that it contains Ashwagandha as the Kalka. Ashwagandha is a good nerve rejuvenator. Normally, patients with spinal canal stenosis, I give Ashwagandha Churna, Ashwagandha Arishta, and Belamula Niruhabasti because Ashwagandha is excellent in managing neural plasticity. To induce a neural plasticity, Ashwagandha has got a tremendous benefit in the condition. So I usually go for a Belamula Niruhabasti in spinal canal stenosis. Also, if the patient is having a spinal canal stenosis, I generally prefer a cervical collar for 5 to 7 days. If there is a severe myelopathy or a radiculopathy, I also advise the patient to go for a cervical collar. In very severe degenerative conditions, sometimes I may oblique because it may become stiff further, but otherwise I generally follow a traction with a cervical collar. This is how I manage a case of cervical canal stenosis. Next is cervical rib. So as you know, the rib starts from the first thoracic vertebra. But as a congenital defect, sometimes what will happen, the ribs may start from the seventh cervical vertebra. You can see they starts from the seventh cervical vertebra. If the ribs start from seventh cervical vertebra, it leads to a condition called as thoracic outlet syndrome. In thoracic outlet syndrome, what is happening is that the lower trunk of the brachial plexus and subclavian artery will be entrapped or compressed between the first cervical rib and the scalenus muscle. If the lower trunk of the brachial plexus is compressed in the cervical rib and scalenus muscle, what will happen? It leads to weakness of the shoulder muscles and atrophy of the hypothenar muscle. That is what happens when the lower trunk of the brachial plexus is entrapped. If the subclavian artery is entrapped, it leads to a reduced blood supply to the hands and leads to claudicatory symptoms. If you want to diagnose whether it is a case of subclavian artery is compressed, you need to go for a test called a Roots test. In Roots test, what you have to do is you need to abduct and adduct the hands continuously slowly for 3 minutes. when we are adducting and abducting the hands for 3 minutes, what will happen? Slowly, the claudicatory symptoms will develop. Here we can diagnose whether there's a subclavian artery is compressed or not. Next, in the clinics, normally my students call me and ask actually, how do we diagnose whether it is from the seventh rib or T1? So normally the cervical ribs will be either straight or downwards. But thoracic, the transverse process of thoracic, not ribs, the transverse process of cervical ribs will be either straight or downwards. But first thoracic vertebra onwards, the ribs will, the transverse process will be projected upward. That is how we diagnose whether the ribs is starting from the first thoracic vertebra or from the seventh cervical vertebra. Next is thoracic spine. So we are completed with the interpretation of cervical spine X-ray. Next is about the thoracic spine. So the disease affecting the thoracic spine is similar to that of cervical spine and lumbar spine, but there are a few notable differences. One is the compression fracture and osteolytic tumors, and as well as osteomyelitis are quite common in the lower thoracic spine. I repeat, the compression fracture, osteolytic tumors, as well as the osteomyelitis are seen quite common in the thoracic spine. Also, traumatically, if there is an injury, because thoracic spine has got a very narrow spinal canal. If there is a traumatic injury to spinal canal, it leads to a severe myelopathy. So here this is a X-ray of the thoracic spine, anterior posterior view. Here the central beam is directed 2.5 centimeter below the sternal angle. This is an AP view of the thoracic spine. You can see the vertebral bodies, intervertebral disc space, the transverse process, and the ribs and dome of diaphragm can be seen in the anterior posterior view. This is when anterior posterior thoracic spine X-ray is taken. This is the lateral view. The lateral view again, the beam is laterally taken 2.5 centimeter below the sternal angle from the lateral side. Here in this lateral X-ray, you can see the vertebral body, intervertebral disc space, intervertebral canal, and the ribs and the dome of diaphragm, the dome of the diaphragm. These things can be very well seen in the lateral view X-ray. This is the compression fracture. So normally in the clinics, the patient comes, especially old age people. Suppose if someone after 60 or 65 comes with a fall on the ground, hitting the buttocks, invariably you should send the patient for a thoracolumbar exercise. Should never write lumbosacral spine. It has to be thoracolumbar spine, because the T1 and T12 is the area which is more likely to get fractured in compression fracture or a fall hitting the buttocks. And in severe osteoporotic spine, if you cuff or if you have a proper twist, that will be sufficient to have a compression fracture. So always go for a X-ray of the thoracic spine if the patient complains with a fall on the ground, hitting a bone with the backache. Never ignore that X-ray and never start with a conservative management. If there is no neurological symptoms, just advise the patient to lie down in the bed, supine, continuously for 2 months. It will heal by its own. After that, you can give a brace, tailless brace or something can be given, but you can manage. Ayurvedists can manage compression fracture thoracic by giving a kartha vattu lebam. In Kerala practice, we generally give a kartha vattu lebam at that side and leaving the patient continuously. And even a male patient, give a bedpan also. Never allow the patient to go to the toilet and take have a passage of urine. So that's about the compression fracture. Here you can see the anterior posterior height has been reduced. Here also you can see the vertebra is completely collapsed. The anterior posterior height of the vertebra is completely lost. This is the case of compression fracture. The T11 and T12 is the most commonest area which used to get fractured. This is the lumbar spine. Here you can see in the lumbar spine AP X-ray, the central beam is directed just below the costal margin at the L3 level. The vertebral height is lesser than the horizontal diameter, unlike the cervical spine. Height is similar to the adjacent one. Next, the disc height. As you know, it's a radiolucent horizontal shadow seen between the vertebral body. You can see this is the radiolucent horizontal shadow seen between the vertebral body. This is the disc height. But there is a difference in lumbar spine. The disc height is progressive increase in disc height. The L1, L2 will be a little lesser, L2, L3 more, L3, L4 more. Likewise, the height will progressively increase till L4, L5. except between L5 and S1. L5, S1, the disc space is normally narrow. So usually every X-ray, if you show to student, they will say that L5, S1 disc space is narrow. But L5, S1 disc is usually narrow compared to the upper lumbar spine. That is the normal anatomy of the lumbar spine. This is a spinous process. As I said, it's better to view the spinous process in the AP view. The spinous process should be always be in the center line. It is very important to see whether the projection of the X-ray is normal or not. You have to look into the spine. If the spine is in the center, it is very sure that the X-ray has got a very proper exposure. If one spine is aligned right or left, it indicates a unilateral facetal dislocation. Also, interspinous distance or should be interspinous distance should be symmetric throughout. If the interspinous distance is increased or decreased, it indicates a unilateral facetal dislocation. Next is pedicles. Always look into the pedicles. This is the oval shaped shadow. This oval shaped shadow. Never ignore looking into the pedicles when you get an AP X-ray of the spine, because osteolytic tumors as well as osteomyelitis destruct the pedicles first. So pedicular destruction will be seen as a first sign of osteolytic tumors or an infective lesion. So always give importance to the pedicles. In the lateral view, it can appears as a rectangular in view. You can see it's a rectangular. This is the pedicles in lateral view and the oval shaped shadows in the anterior posterior view. This is the facetal joint. You can see the facetal joint. These are the linear oblique radiolucent shadow. These are the facetal joints. In facetal hypertrophy can be made out from the lateral X-ray. Then pars interarticular is a very important structure as far as X-ray is concerned, because the region between the superior articulating process and the remainder of the lamina is called as a pars interarticularis. It can be very well seen if you go for an oblique view X-ray. In an oblique view X-ray, can you see a dog here? This dog is called a Scotty dog. This is the Scotty dog. The neck of this Scotty dog corresponds to the pars interarticularis. This area is called as the pars interarticularis. This area is called as the pars interarticularis. That means the neck of the Scotty dog. You can see the mouth of the dog, the ear of the dog, the neck, the legs, and the body of the dog. So the neck corresponds to the pars interarticularis. Why it is important? That's coming in the later slides. Then the transverse process, it is apparently seen on the sides of the vertebra. You can see the transverse process. This is the articular surface. Always look into the articular surface, because bony erosions will be made out from the articular process. So normally the smooth sclerotic surface of the vertebra is called as the articular. So always look into the articular process. That's very important in diagnosis, radiological diagnosis. This is the gas shadow. You can see it may imitate a lytic area. You may suspect as light, but these are not lytic area. These are gas shadows, like us from the bowel. These are not lytic areas. This is Cupid's bow condor. The Cupid's bow condor is not a disease. It is a normal variant. That means unusual flat surface of the non-flat surface of the inferior end plate of the vertebral body. Usually it is a flat surface. Here, non-flat surface of the inferior end plate. It resembles that of the bow of the Cupid, resembles the double curve of the human upper limb, the Roman god of erotic love. That is why it is called as Cupid's bow condor. It is not a pathology, it is a normal variant. Now, say soya shadow. This soft tissue shadow is very, very important, especially when for Panchakarma. Before doing any Panchakarma, just look into the soya shadow. Why soya shadow is very important, you will understand in the later X-rays. This is the pathological findings of the lumbar spine. Here you can see in the right hand side, there is in the right side, the soya shadow is present. In the film, it's a left. And in the left side, the soya shadow is completely absent. The soya shadow is usually absent whenever there is an infection in the thoracic spine or upper spine, and the pus drains into the soya shadow and it obliterates the shadow. Or if you have got any bleeding pathology, if there is a rupture of an intestine or any such causes can lead to the obliteration of the soya shadow. So in Pott's pain, in osteomyelitis, always soya shadow will be absent. You will see more films later on. So look into the soya shadows always. This is lembocycle. You can see in the L5 the transverse pose of L5 is free. This is the normal X-ray. But many a times what will happen, the transverse pose of L5 will be fused with the sacrum. That is called as lembosacralization. Sometimes it could be unilateral or it could be bilateral. There's a controversy regarding whether this lembosacralization causes pain or not. So in my clinical practice, I feel that many patients with the lumbosacral do have a low back pain. The reason is that usually with the lumbosacralization have a thin disc at L5S1. So they will have a lumbosacral strain and patient generally presents with the pain. This is a schematic representation of unilateral lumbosacralization. Suppose if the disc of L5S1 collapse also, what will happen? There can be a lumbosacralization in degenerative joint disorder. This is a congenital defect. This is called as lumbosacralization. This is degenerative joint disorders. First is smaller knots. Smaller knots are usually better seen in the MRIs. This is a smaller knot, this is a smaller knot. These smaller knots are protrusion of the disc material into the weakened part of the vertebral end plate and causes a marrow edema. Here you can see MRI, you can see the marrow edema. So this weakened part of the end plate causes the disc plate to enter into the vertebral body and causes a marrow edema, and it can cause a pain at that particular site. That is a small as knot. Some patient may exhibit pain, some may not exhibit it. But if there is a marrow edema, usually it presents with the pain. And X-rays will generally not visualize smaller knot, but MRI is required to diagnose a smaller knot. This is the lumbar spondylosis, as you know. Here you can see what you can see. There's osteophytic lippings. There's a marginal sclerosis there. Scoliosis. This is called as degenerative scoliosis because there's a destruction of the disc which leads to the scoliotic changes. This is a lumbar spondylosis. Again, one more X-ray, you can see a large beak, osteophyte. These osteophytic lippings are actually a helping thing. It generally helps our body to prevent the disc from slipping or protruding outwards. That's actually this is an accommodative process by our own body. Here you can see a long osteophytic lippings. Here you can see a disc is collapsed and it results in scoliosis, and the bone mineral density is reduced. It leads to a diagnosis of degenerative joint disorder with the degenerative disc disease, DDD. And this is vacuum phenomenon. This is very important. Here you can see there is a black radiolucent shadow. This black radiolucent shadow is mainly because of the gas produced by a degenerative disc. It will never happen in infective pathology. Suppose if this black shadow is not seen, vacuum phenomena is not seen, I will definitely refer this patient for MRI to rule out a infective spinal disease. But since vacuum phenomena is seen, I have diagnosed it as a case of lumbar spondylosis or degenerative disc disease only, because vacuum phenomena is seen only in degenerative joint disorder. Always look, so that can help sending a patient for an MRI further. That is vacuum phenomena. This is fish vertebra sign. This is a biconcave. Usually the vertebra of fish resembles like that of a biconcave disc. In patients, in human beings, when in severe degenerative vertebra, what will happen? There will be a biconcave disc-like structure will be there. That is seen in case of severe degenerative spine. This is called as fish vertebra sign. Next is an empty both sign. Here there is a lucid center. The bone mineral density of the center will be completely lost with the peripheral thickening. This is an empty both sign seen in severe degenerative disease. This is empty both sign. There's a verticalization of trabecula. Normally in the vertebra, there will be a normal trabecula will have a vertical lines as well as transverse lines. Horizontal line, not transverse, horizontal lines. In severe degeneration, what will happen? There will be there will be a rarefaction of the horizontal line. The horizontal lines will be destructed and only vertical lines will stay. Here you can see. That is called as verticalization of trabecula. Here the horizontal lines are absent. This is called a verticalization of trabecula, is seen in severe degenerative bone disease. So normally lumbar spondylosis, it can present either as a Kadigraha or as a Gridrasi. So normally either it's a Kadigraha or Gridrasi, you have to go for a Sthaniga Chikitsa. As a Sthaniga Chikitsa, it is always better to start with the Kadivasti because Kadivasti does not involve much of the manipulation. At the same time, at a particular spot, we can add particular oil. If there is shofa at their side, you can use Kotanjukadi Taila. You can use Dhanvantara Taila if there is too much of degeneration. Likewise, actually, you Mahanarayana Taila. Depending upon the condition, you can use the Taila for Kadivasi. I generally start with the Kadivasi instead of Patrapodlisyoda, etc. Because Patrapodlisyoda and in degenerative spine, when you tap, it may cause again. But Kadivasi is better to reduce the acute pain in the morning, Kadivasi, and the evening before sleeping. I generally prefer a Nadi Sweda because Nadi Sweda also relieves the muscles passed to the extent. After that, in Kadiyasrita Vada, it is better to go for a Vada Nilomana. Virajana is given. In Kerala and Ashtoida practices, we generally go for Erenda Taila with Nirgundi Swarasa. In Kadiyasrita Vada, it's a miraculous preparation. Means where Nirgundi Swarasa 30 ml mixed with 15 to 30 ml of Erenda Vada and proper Vada Nilomana is given. It itself reduces the Kadiyasrita Vada and pain will be relieved to the certain extent. Then Madhu Tailiga Basti and Dashmula Madhu Elio Basti, Dashmula Shira Basti, or and finally a course of Shastika Shali Pindasweda is also done. That is the general principle which is adopted in case of lumbar spondylosis. Then lumbar traction can be given. Traction is one way good. It can help the patient to lie down without a movement for some time. But if you give a lumbar traction, always elevate the lower end of the bed and give a traction. Otherwise, it won't be any benefit. It won't offer any benefit. Next is spinal canal stenosis. I said normally spinal canal stenosis cannot be visualized in the X-ray, but here in this case, you can see the posterior osteophytes are encroaching the vertebral canal. You can see the posterior osteophytes are encroaching the vertebral canal. It causes it leads to a spinal canal stenosis. If the patient has got a symptoms of spinal canal stenosis with this X-ray, it is very evident that there is a case of spinal canal stenosis because posterior osteophytes are encroaching the spinal canal. Here you can see this. If you take an X-ray or MRI, you can definitely find a disc osteophytic complex is compressing the spinal canal. Will be seen in the MRI. Next is autoimmune disease of the spine. Suppose if a young patient of 20 or 30 presents with the aching pain in the sacroiliac joint with the oligoarthritis of more than 3 or 4 joints will be severe pain and morning stiffness of 3 or 4 joints with the reduced spine movements, especially the lateral movements will be affected, or the Schauber's test is positive, then we have to suspect ankylosing spondylitis. I repeat, if a patient in the 20s or 30s comes to you saying that there's a sacroiliac pain with the difficulty in bending forward, with the oligoarthritis, more than 3 joints has been affected with the severe pain and early morning stiffness, you have to suspect ankylosing spondylitis. If you suspect an ankylosing spondylitis, you have to go for the physical examination like lateral bending, Schauber's test, etc. Later, the radiological investigation has to be carried out. The best radiology first a plain X-ray of the sacroiliac joint. In the initial, if the patient is with the acute presentation of sacroiliac pain, then here you can see sacroiliitis. Both the area you can see there is a sclerotic changes with a widened gap. This is because of the inflammatory edema of the cartilage. In the initial stages of the ankylosing spondylitis, you can find an inflammatory edema. Later, after some time, you can see the cartilage will be completely destructed and fusion and fussiness of the joint. You can't see any joint margin. There's a complete fusion of the sacro. So sacroiliitis is one diagnostic of ankylosing spondylitis. Then you can go for an X-ray of the spine. X-ray of spine, you can find bony bridges between the vertebrae. This anterior longitudinal ligament will be completely deposited with the syndus, bony bridges between the spine. Ossified spinal ligaments. Then vertebrae appear squared. This is very important. Here you can see this vertebra is almost appears square. Squaring of vertebrae is very specific to seronegative spondyloarthropathy. The squaring of vertebrae is generally seen in case of seronegative spondyloarthropathy. And you can see there is a sclerotic changes in the arterial body. That's also very specific. So squaring of vertebra and sclerosis of the anterior vertebral body with bony bridges is diagnosis of ankylosing spondylitis. This is a bamboo spine. You can see a full formed bamboo spine, a single segment of bone fused with the fusion of sacroiliac joint. Very diagnostic of bamboo spine. Anyone can diagnose. Also, here you can see a wiring at the posterior spine. Normally, whenever a patient presents with a severe ankylosing spondylitis, usually the therapist say that the neck is very stiff. We need to manipulate. Never attempt to manipulate a patient with the ankylosing spondylitis because it leads to a condition called chalk stick fracture. Never try to manipulate too much. Okay. Next sign is called a dagger sign, like an inverted knife. You can see it is mainly because of the syndesmophyte deposition of the intraspinous and supraspinous ligament. Intraspinous and supraspinous ligament calcification leads to a sign called dagger sign. There's one more sign called the trolley track sign. You can see these are three lines. One is the calcification of the interspinous and supraspinous. Second is the syndesmophyte deposition of the epiphyseal joint capsule. These three lines, 1, 2, and 3. That's a trolley track sign. Again, diagnostic of ankylosing spondylitis. So ankylosing spondylitis in our clinical practice generally points out towards the diagnosis of Vadarakta. So in such condition, I generally prefer, I don't usually follow the usual typical path because in a Swedana, if you give Swedana, initially patient may get some relief, but after some time the pain will aggravate. In the initial stage of my clinical practice, since considering a stiffness, I usually give Swedana, etc. But Swedana causes more vasodilatation, more syndesmophyte deposition, and aggravates the condition in the long run. So I normally follow a Rukshana Basti, that means Legana Basti, then later Abhinga without heat. And if you do Kaya Sega with a milder temperature, 20 degrees centigrade, I may go for a Kaya Sega or a Pilchil. And I advise the patient to lie down in the prone position and go for a stretching exercise, yoga, and if possible, swimming is the best exercise. If they know swimming, if they can, swimming is the best exercise they can do with the ankylosing spondylitis. And regularly Abhinga, means weekly once, I tell them to come and have an Abhinga with the stretching exercise. Next condition, here you can see that's a diffuse idiopathic skeletal hypertrophy. DISH, I will call it DISH. It may be misdiagnosed as ankylosing spondylitis many times by students, because in DISH, what will happen is you can especially seen more in the thoracic spine and in cervical spine also. Sharp projecting osteophytes will be there. Sharp projecting osteophytes. That's this is called as flowing osteophytes. Flowing osteophytes in contiguous four vertebrae. The flowing osteophytes in contiguous four vertebrae with sharp borders is diagnostic of diffuse idiopathic skeletal hyperostosis. In our treatment, we can be considered as an Adhyasthi, and Dashmula Niruha Basti is the Basti which is generally given in diffuse idiopathic skeletal hyperostosis. And that projection does not cause any pain, but this projection may cause injury to the nearby soft tissues. And a patient with the diffuse skeletal hypertrophy, when you send for an endoscopy or something, be careful because it can rupture the esophagus, etc. Always be cautious to do endoscopic procedures in diffuse idiopathic skeletal hyperostosis. Next is neoplasms. Suppose if an old patient above 70 or 80 comes to saying that there's a severe bony pain, similar to that of a rheumatic pain, with a severe night pain, anemia, and recurrent infections of lungs or a UTA, but always suspect about multiple myeloma. In such condition, what you have to do is you have to take an X-ray of the spine. In the spine X-ray, what you can see collapse of multiple vertebrae. Multiple vertebrae has collapsed, but without any apparent disc space reduction. That's very important. Without any apparent disc space reduction, the multiple collapse of the spine has happened. So an enlarged vertebral foramina, again diagnostic of a primary malignancy. Here in this another X-ray, you can see a big enlarged vertebral foramina, collapsed vertebra, but this space is still maintained. Again, we grew more doubtful about the multiple myeloma. Then what you have to do is you need to go for one more X-ray to see the soft tissue. You can see paraspinal soft tissue was enlarged. Always there will be paraspinal soft tissue enlarged will be seen in multiple myeloma. So here one more, you can see this is the pedicle. This is the pedicle. Here pedicle is lost. Why I said it is important to look into the pedicle, because usually in osteolytic tumors as well as in infection, pedicle will be lost. This is called as missing owl sign, missing our own eye sign. Here the pedicles is absent. Next, you have to go for an X-ray of the flat bone, either a pelvis or a skull. You can see multiple puncture out lesion, a raindrop appearance, or a moth-eaten pattern, which is very diagnostic of multiple myeloma. If it is because of a degeneration, if this osteolysis is because of a degeneration, surrounding sclerosis will be seen. But here there is no surrounding sclerosis, which is indicative of a multiple myeloma, a moth-eaten pattern. If you doubt, then you can send for a protein electrophoresis. Protein electrophoresis cleans the diagnosis of multiple myeloma, or Benson's protein in urine is also another test. Now, say secondaries in spine. Secondaries in the spine means there is an increased radiosity of a single vertebra without any increase in the size and contour. It is usually seen in metastasis. Metastatic from the prostate, metastasis from the breast, etc. causes a ivory vertebra sign. Ivory vertebra sign is usually a metastatic deposit. It can happen in a benign condition also, in severe degeneratively multiple fractured bone. This is an ivory vertebra, same patient who had a MRI took, again there's a metastatic deposit, and this is a PET scan which shows a primary at the prostate, and these are prostate deposit. It was my own patient who lived up to 74 years. There's an infective spinal disease. So even though the relevance of tuberculosis of lungs or pulmonary tuberculosis reduced, but still the prevalence of port spine is still rampant. Always whenever you get a patient with the back, always think that it could be a port spine. Rule out port spine in every low back patient, because it is still rampant in our community. Many patients are coming to us with the port spine, and we are not diagnosing it properly, and results in ports paraplegia. So always think of a port spine when you get a low back pain patient. Here you can see there is a destruction of the disc. The disc is completely destructed, with a huge paraspinal soft tissue, Then vertebral height is reduced. It is diagnostic of an infection. Here you can see the pedicles are destructed, the disc is destructed with a big lytic area. Again, it indicates here you can see fusion of the vertebra with the end plates are not seen. So again, diagnostic of a port spine. Or any infection. It could be staphylococcus, or it could be brucellosis, but still there's an infection. Here, this is a port spine gibbus. Because of a collapse of the vertebra, there's a sharp angulation as obtained. This is called as port spine gibbus. So normally, if you massage a patient with the port spine without diagnosing, it results in port spine gibbus, and finally port spine paraplegia. So always be cautious. So port spine gibbus seen from outside. Next is the metabolic disorders of spine. So this is a case of Paget's disease. In Paget's disease is sclerosis, widening, and softening of the bone. So Paget's disease is a metabolic disease where there will be destruction of the osteophytes. So osteoclastic activity will, few osteophytes will be destructed. So what will happen when few osteoclastic destruction happens? Osteophytes will be formed, or osteoblast will be deposited. So destruction, or in the medical term, it is called as destruction followed by formation. So continuous destruction and formation leads to a soft, enlarged, deformed bone. That is the hallmark of Paget's disease. Here you can see widening and sclerosis and collapse. If you take an X-ray of the skull CT, you can see there is a widening with the widened areas, destructed areas. This is called as cotton wool appearance. Very diagnostic of Paget's disease, because that is a few osteophytes will be destroyed, osteoclast will be formed, then osteoblast. So destruction and formation of the bone leads to a deformed bones, leads to a cotton wool appearance. Here you can clearly see the cotton wool appearance of the skull. Then picture frame appearance, or a bone within bone appearance is seen in spinal cord. You can see it's a reinforced peripheral trabeculae with a loosened center. I repeat, reinforced peripheral trabeculae with a loosened black center. That is a picture frame appearance. That is a hallmark of Page's disease. Gouty arthritis. So normally in the X-ray, generally does not have much role in diagnosing gouty arthritis, but in the present clinical practice, if a patient presents with a full tenderness all along the spine, it could be an enthesopathy due to a gouty arthritis. The uric acid level may be normal, but still patient can have a gouty arthritis. If there's a complete tenderness of the spine, then you have to always suspect enthesopathy due to a gouty reaction. So always advise the patient to avoid alcohol, red meat, lentils, and tell him to drink plenty of water and reduce the weight. That's very important. This is an MRI of a patient with a gouty arthritis. You can see in the spinal cord there is a deposit. When surgically it is removed, it is found to be a gouty toffee, and the patient had a paraplegia following that. So even it can affect the spine. So normally, as it generally project as a Vadarakta symptoms, Parisega, Sharabasti, and Shirabasti. Usually Parisega with the Dashmula Koda, Manjishtadi, Sharabasti, and Madhyashti Shirabasti is indicated. And if the patient is having severe burning sensation, we give Pindadailam. Kerala, we generally advise Pindadailam, which is very well in reducing the burning sensation and pain in gouty arthritis. Next condition is alkaptonuria. Alkaptonuria is nothing but it's a genetic disorder where there will be defect in the tyrosine metabolism. Due to a defect in the tyrosine metabolism, there is a defect called the homogenetic acid oxidase enzyme will be absent. It results to a lot of production of homogenetic acid. Homogenetic acid distracts the cartilage and forms a calcification of the cartilage. The calcification of the cartilage is seen only in alkaptonuria, and patient may need to go for a complete hip replacement by the age of 18 or 20 if the patient is having a alkaptonuria. It is also called as black urine disease, or if your earwax exposed to the sun air, it leads to black. This developmental disorder. One is the spondylolysis. Here you can see the pars interarticularis. The pars interarticularis will be absent, or there's a fracture of the pars interarticularis. This is called as spondylolysis. To diagnose a spondylolysis, what you have to do, you have to take an oblique view X-ray of the spine. In the oblique view X-ray, you can find a Scotty dog. As I said, this pars interarticularis corresponds to the neck of the Scotty dog. Here in this X-ray, you can see here there's a properly seen neck. This pars interarticularis intact, but here you can see the Scotty dog, the neck is absent. So this is a case of spondylolysis or a defect in the pars interarticularis or a fracture of pars interarticularis. This is spondylolysis. Spondylolysis leads to spondylolisthesis. You can see if the connection between the anterior part of the vertebra and posterior part is lost by the fracture in the pars interarticularis, it leads to a spondylolisthesis. Spondylolisthesis can be graded into 4. If one part, the vertebral body has been divided into 125, second 25, third 25, and fourth. If one part is slipped front, it is called as grade 1 spondylolisthesis. If 2 is slipped, it is called as grade 2. This is a grade 2. So likewise, spondylolisthesis is different. If a patient with a spondylolisthesis, what you have to do is the patient presents with a spinal canal stenotic symptom. But always, I generally prefer to give a Kadibasti and Nadisyoda for 7 days and advise the patient to lie down in the bed continuously for 2 weeks. So that when 2 weeks the patient lie down in the bed without getting up, you better use a bedpan. The defect area will be corrected to some extent and patient will be all right. But 3 weeks of complete bed rest with the don't do Abhyanga and all continuously for 2 weeks, it's not good. A course of small Kadivasti, later complete bed rest for 2 days generally improves the condition of spondylolisthesis. Even in grade 3 spondylolisthesis, I got good results with this approach. Next is scoliosis. So either right or left bending of the spine is called as scoliosis. So if you want to, if you suspect a scoliosis, what you have to do is that you have to tell the patient to bend down. It is better to seat the patient and tell to bend down. And if you can see a hunch or a bump at that level, then it is diagnostic of scoliosis. Especially in females, by the age of 12 or 13, there's a condition called idiopathic adolescent scoliosis. Usually the scoliosis comes to the right side. If it is to the left side, it will be more dangerous. And whether we can treat the scoliosis or surgery is defect, for that you need to assess a test called the Cope's angle test. If the Cope's angle test is less than 20, we can manage the patient. If it is more than 20, better advise surgery to the patient. Now in the mobile, you can get an app how to measure the Cope's angle, but I now still use a protractor to diagnose Cope's angle test. You can use a mobile app. I'm not good at technology, so I not use that, but it's available in the mobile apps. If there is a scoliosis, again, a traction massage is sometimes given with the complete bed rest for 3 weeks, so that the further progression of the scoliosis can be prevented. And to make sure that it is not a functional scoliosis, if it is a functional scoliosis on bending down, bending down, that will be corrected. If one leg is small, give a proper footwear, etc., and try to correct that. That's a spina bifida. You can see normally during the growth phase, there will be, if folic acid is not taken properly, there will be a defect in the spine. You can see this is called a spina bifida occulta. There is a defect. Here also you can see the spine is not fused. This is spina bifida occulta. Here you can see a tuft of hair, and you can see a fat part bend. This is spina bifida occulta. So my presentation is over. There's a small tutorial for 5 minutes. Should I continue or should I stop now?
Yes, sir, you can continue.
Continue. Thank you. So this is an X-ray. This is a patient, a 24-year-old boy came to me from allopathy hospital. He came with a back pain and he was there in allopathy hospital. They took this X-ray and the patient didn't get no relief, so he came to me. So when I viewed this X-ray, I found at the T11 level there is a erosion. You can see a erosion here, and the disc space is reduced at this level. Then I will look down. You can find here the soya shadow is seen. Here soya shadow is absent. When I look further, you can find the transverse process of here is distracted. Here you can see the rib. This side rib is not seen. So I find that it could be a infective condition. It could be a port spine. I referred the patient for an MRI. This is an MRI. You can see a disc destruction, paraspinal soft tissue swelling. This is a huge psoas abscess collection. 300 ml of pus was there in this patient, but only on medicines, anti-tubercular medicine, the patient became safe. But without looking properly into the X-ray, if would I have done a massage, Abhinga, the patient, the young boy would have been landed up in a Port's paraplegia. It's a Muhammad Salam, a 24-year-old patient. So this is the importance of viewing X-ray in the clinical practice. From this X-ray, you might have got the importance why viewing X-ray is very important in the clinical practice. Many a times we may land up in many complications if you won't visualize the X-ray and go ahead with the treatment. Next, again, this X-ray, we can see there's a fish vertebrae sign, and at here you can, even though there is a fusion, almost nearly damage of the disc, but still you can see a black radiolucent shadow. That's a vacuum sign. So it is a case of with the empty box, and you can see the peripheral trabecula is accentuated, but the lucid center. So osteophytes, a vacuum deposit, fish vertebra sign, a case of degenerative joint disorder. In this X-ray, you can see a scoliosis. It's a degenerative scoliosis because a vacuum sign with a scoliosis with osteophytic lip wings. It's a degenerative scoliosis with the, you can see lumbosacralization. The transverse process fused with the sacrum on both the sides, bilateral lumbosacralization. This calcification is a calcified fibroid. One more case you can see from the straight or downward spine, that means transverse process, that means C7 spine, there is a rib that is called a cervical rib or a supernumerary rib or a neck rib. Here what you can see, actually I need to ask to you and you need to reply, but since time is not there, I'm just going ahead. You can see there's a slit between the spinous process, a spina bifida occulta. This is a case of spina bifida occulta, which can cause a low back pain. And thank you one and all, especially my dear teacher Ved Patak sir, for giving me such an opportunity to present at this prestigious institution. If you have got any queries, you can ask fast, or you can reach me at my WhatsApp, or regarding the opinion about the class or any suggestions, you may reach me by drshibu.varghese@yahoo.com.
Thank you very much, much, sir, for such informative talk. I may request our learned audience to text their queries for Dr. Shibu Varghese, sir, which will be entertained at the completion of the second session. With this, I would like to initiate the second session. This session is coordinated by Dr. Vipin Tawar, Faculty of PG Department of Panchakarma INIA. Handing over the platform to you, sir. Good. Attendant speaker of the session is Dr. Muralidhar Pujara, sir. Pujara, sir, is postgraduated from Kayachikitsa stream and has obtained PhD from GSRAU Jaipur. Presently, he is working as in Panchakarma department and simultaneously handling the office as medical superintendent SDM College of Ayurveda and Hospital Hassan. Dr. Pujara is renowned practitioner, teacher, and delivered several lectures at various national and international platforms. I am handing over the session to Dr. Muralidhar Pujara, sir. Thank you, sir.
Good afternoon, sir. Am I audible to you, sir?
Yes, sir.
Yes.
Yeah. Most respected Honorable Director, Nationalist of Ayurveda, Jaipur, Dr. Ved Pathak, sir, Honorable Head of the Department of PG Studies in Panchakarma, Nationalist of Ayurveda, Jaipur, and today's resource person, Dr. Shibu Varghese, and all the faculty members and the registered delegates of the program. Before starting my presentation, I would like to put some light on the COVID pandemic, what I have understood regarding the COVID pandemic. Just I wanted to share my views regarding this COVID pandemic. Just I made the information like a small chapter. I have titled it as the COVID Navadasha. Before starting my concept or discussion on sleep disorders, let me share my view, what I have understood regarding the COVID-19. It starts like Bharatasya jata pravruddhaha vishwavyapakaha, means it has come from other parts of the world. Covida Navadasha Kyataha Janapada Dvamsa Karanam. So it is called as COVID-19, and it is the reason for pandemic Janapada Udvamsa. Next, I have highlighted how it spreads. Jalabindu nipatena krimihi sevati manavam. So by the water droplet at when it was started during March, April, May, June, that time, it was a very common discussion. The water droplet, the virus enters to the water droplet like that. Then pranavaha srotasam hatva dhatvagnim hantiyopya. Here I have included the dhatvagni. It hampers the dhatvagni, and in turn it lead to affect the functions of the pranavaha srotas. So this is the nidana and samprapti I have understood in this manner. Then the symptoms, the lakshanas, what we have observed during that time. Tivrajwaram Shwasakasam Pratishaya Mato Balihi. The Balihi term is mentioned. It means that the symptoms will be very severe. Then Hatvacha Ojasam Krutva Prananchapi Vinashati. It is a fatal also when it is become very severe. Then for the prevention, what I made is Hastanairmalyanam Krutva Shwasanairmalyanam Param Janapadasya Antaram Bhutva Manushanam Cha Rakshatam. So this is Manushanam Cha Rakshatam. For the prevention of this pandemic, what are the three important measures were in practice at the earlier? Hastanairmalyanam, of course, now also it is in practice and it's most important. The hand hygiene, respiratory hygiene, and Janapadasya Antaram is the physical and social distance to be maintained. So Manushanam Cha Rakshatam for the prevention of spread of infection. Then I have put some light on the treatment principles here. Sannipata Jwara Proktam, Jaha Jwara Chikitsitam, Rasayanam ch Proktam, Covidanam. Usually, our treatment goes like Samshodhana, Samshamana, then Rasayana, Brahmana and Rasayana. Samshodhana, of course, it's Sannipata Jwara Chikitsa. Siddhanta has to be, can be adopted here. After Shamana Chikitsa, usually when symptoms will be reduced, then the Rasayana Chikitsa, like Kumara Varana Rasa and other modalities can adopted for the prevention. Haridra Bhavitam Kshiram, Hema Kshiram Paramat. There was a practice, the Haridra Kshira, it was calling as the golden milk. So I have termed it as Hema Kshiram Paramataha, Javana Prasasa Sevena, Rogasya Niyatam Bhavet. So these are the things what I have understood regarding COVID-19. I'm very much thankful for listening my views on the COVID-19. With this, I would like to start my presentation. Just slides. Full screen. Full screen. Management of sleep disorders with special reference to insomnia. This is the topic allotted for me. Well, at the outset, by thanking for the organizers, I would like to start my talk on the concept of sleep and insomnia and its management, especially in day-to-day clinical practice, more and more with the Panchakarma techniques. First, I would like to brief on the physiological aspects of the sleep and sleep disorders. Of course, when we look into the classics, at a stretch, the information about the sleep disorders may not be available, but when we search the classical textbooks of Ayurveda, we get plenty of information regarding the sleep. As our Honorable Director was telling in the inaugural address, Sir has a stress on the Trayopastambhas, which are very much important for leading the life, Ahara, Nidra, and Brahmacharya. And Sir has stressed on the importance of Ahara, and the equal importance should be given for the sleep also. So I would like to give some information regarding sleep. What is the concept of sleep explained in the textbooks of Ayurveda? Nidra, it's a transient resting state of mind and body. Of course, transient means episode, one episode, it will be resting state, and after some times, when once again the cycle is completed, then the person will be into the state of awakens, and when the exhaust or the he will have the clamor or fatigue, once again he go for the state of resting state. That can be termed as the term nidra or sleep. Second information, of course, all these things happen from different textbooks of Ayurveda and other darshanas and other texts also. Nidra is a state wherein the soul is free from external activities. So that is similar. It is the resting state of the mind. When we refer the dictionaries, Nidra is a term which is a combination of two words, Ni and Dra. The term Ni or the letter Ni refers to Nisha, Dra is the Karmavachaka, means the process. The physiological process or resting state during the Nisha or the night time. So that resting state of the mind during the night time has been termed as Nidra. Then just I have taken one reference from Shastoma Mahanidhi and Shabdakalpadruma. Nidra ityukte vishayebhyo karmendriyanam vyaparo aparamarope jivasya avastha vedaha iti nidra ityuchute. Means mind or indriyas are having different arthas, and they will have some vishayas. When these vyapara, the activities, here the term vyapara refers to the activity. When this activities of different indriyas will be in the state of rest, that jivasya avastha is avastha vedaha. So that is called as nidra. It means the state of life where sensory and motor functions are at rest. So the term jivasya is meant there. That's what I have taken it. Consider the term the state of life. Shabdakalpadruma explains about nidra, medya, mana, samyogaha. So means sleep is the resting state of intellect. So whatever the vyavahara intellect I would like to call here, it as the buddhi. Buddhi means the sarva vyavahara hetuhu buddhi, and ya buddhi sa nischayatmika. So whatever the things we do every day, they are all by the intellect, and whatever the decision, ya buddhi sa nischayatmika, whatever the decision we take, that is by the buddhi only. So whenever in the state of sleep, we will not be in a position to do any activities, or we will not be in a position to take any decision like that. That's what the Shabdakalpadruma has explained about nidra, medhyamana, samyogaha. Vaspatyam explains sarvalokaha samakshuddhaha yadara yamena ratrishu yogena samanyena. Here I would like to give some comment on ratrishu yogena samanyena. It is the resting state of the mind and body, usually during the night time. So during the ratri. Question is what about the sleep or the resting state in the daytime? I would like to comment on that as when we do this, when we go for sleep during the daytime, it is a divanidra. Rest nidra will be called only during the night. So when we take the rest during the night, then only it will be termed as nidra. Then Sharangadara explains sleep as sa, nidra, tamakafabhyam. So here I would like to comment on the dosha. Here onwards, the involvement of dosha start happen for the discussion. Tama and kapha, here two doshas are there. Kapha is the sharirika dosha and tamas is the manasika dosha. It means that nidra is having the involvement of both mind and body. Say both involvement of both mind and body is having, to denote the kapha and tamas are involved. Adamalla, the commentator on Sharangadara Samhita, has commented the same term, at the same instant on nidra as nidra swapnecha sa tamakafabhyam sat tamoguna kafa samsargena bhavati ityarthaha. Means in the previous, when we talked on the Sharangadara's description, tama and kafa are responsible, but here tama kafabhyam sat tamoguna kafa samsargena. So tamoguna, when it mixed, or it also be considered as kapha is having tamoguna, when that tamoguna buddhi of kapha takes place, then definitely the person wants to take a rest. That resting state is called the sleep. Nidra indriya manomoha and nidra medhyamana moha, medhyamana samyoga. They are the two other informations or definitions also given by Acharya Adamalla in the same context in Sharangadara Samhita. Then physiological aspects. Previously, what we have discussed, there are all the definition, what we can understand regarding the sleep, what is the meaning of sleep. Then the physiological aspects of sleep. Almost all the Brahotrais have explained about the physical aspects of sleep in while explaining the Staulya in Charaka Sutra Sthana, the physiology of the sleep is explained, and in Sharira Sthana, while explaining Hridaya in Sushruta Samhita Sharira Sthana, the concept of sleep is explained. So when we explore different samhitas, Charaka, Sushruta, Vagbata, Vela Samhita, Harita Samhita, different literatures, we can get more and more information, different information regarding the sleep. Here I would like to quote a few of the physical aspects of sleep. First, Ashtanga Hridayakara's description. Ashtanga Hridayakara explains sleep as Shleshma Vrteshu Srotassu Shamad Uparateshu Cha Indriyeshu Swakarmebhyo Nidra Bhavati Dehina. On the same context, with a similar meaning, Charaka has explained Yadatu Manasi Klanti Karmatmana Klamanvitaha Vishayebhyo Nivartante Tada Swapati Manavaha. So when person will have some sort of tiredness, klanti or klama. Klama is a fatigue. Of course, there are different meanings of klama. Klama, another meaning is niraya, so jannashamaha, klamaha. So that is in the diseased aspect, and it is the physiological aspect. Here, the shrama or the exhaustness or the tiredness, which is caused because of the work during the daytime, that can be considered as the klama. So during that exhaustness or the tiredness of the mind and the body and mind wants to dissociate from its functioning. That's what Charaka has quoted here. Vishayebhyo nivartante. So when this dissociation from the indriyarthas or the activities, tada swapati manavaha. During that time, the person will go for sleep. And Hridayam Chetana Sthanam, of course, some mistake is there. It is Vagbhatacharya is mentioned. It is Sushruta's description. Hridayam Chetana Sthanam Sushrutam tu Dehinam Tamopi Bhute Tasminstu Nidra Vishati Dehinam. Here the term Hridaya is taken here by Acharya Sushruta. Hridaya is, here we can consider Manasthana Hridaya. So that is the Chetana Sthana. So when the mind is covered with or engulfed with the tamas, then person will go for the sleep. Acharya Dallana comments on the same as Tasmin Hridaye Tamasa Tamogunona Chitena Avrute Niruddha Sati Sarva Praninaha Swapnati. That's what I was asking. So Manavaha Srotas and Manasthana Hridaya, when it is engulfed or avrita or covered with this tamoguna, then the person will go for his physiological sleep or normal sleep. Based on the physiological factors involved in the sleep can be classified. So we have seen almost all the different definition of the sleep and different theories of sleep physiology, Charaka, Sushruta, Vagbhata, and their commentators. We can come to conclusion that, or we can say that, or we can classify this sleep as sleep occurred by tamas, sleep occurred by shleshma, then sleep occurred by mental exhaustion, sleep occurred by physical exhaustion, and the last one is sleep. Natural sleep causes every night. So that is the samanya nidra. So the same classification has been told by Acharya Charaka. I have taken the reference from Charaka's Tamobhava Shleshma Samudbhavacha, Manas Shariras Shamasambhavacha. So that the same information I have taken here. And there are two things are there indicative of bad prognosis, that is the Avantuki Nidra and sleep caused as a complication. As a complication, the patient will go for Nidra or Atinidra. So they can also be, they are also considered as the types of sleep. So regarding sleep caused as a complication and as a symptom, I will discuss later in my presentation. The benefits of sleep, as I'm talking on the physiological aspects of sleep, I would like to mention this Nidra Yatam Sukham Dukham Pustikasham Balavalam Pushatam Klibatam Jnanam. It means that the Sukha or Dukkha, they are the mental status, sorrow, happiness. Then Pusti, Karsha, they are the physical status. It means that the nourishment or not good nourishment. Bala and Abala, the strength and other things. Rushata, Klibata, Jnana and Ajnana, the knowledge or grasping, understanding the things. They're all the things, they're all very day-to-day routine things which we are we can come across every day. All these things or depends on the proper and improper sleep. I think many times we have experienced when we do some work during the late night hours, which is a proper time or the natural time to take rest in the means of sleep. When we are not utilized it properly for sleep, then definitely the next day will be disturbed. So this particular quotation gives importance of sleep and the benefits of sleep. Then sleep and prakriti. There are some information regarding sleep and prakriti in the classics. Usually, the Kafaja prakriti and Tamasika prakriti people will have more and more sleep. And one more information is sleep and kala. During the Kafa kala and Tama prabalya kala, we go for sleep. And Nidra is mentioned as one among the Adharaniya Vega also, right? Among the Trayodasha Adharaniya Vegas, Nidra is mentioned as one among the Adharaniya Vegas. It is a physiological, it's a normal one. If it is not done properly, if Nidra Dharana is done, then there may be chances of many complications. And Nidra is mentioned as one of the assessment factors of the Chikitsa. So it is told in Charaka Vimanasthana 8th chapter, while explaining the Dashavidya Pariksha Vishayas, Karya Phala, after treating the patient or after administration of the treatment, the effect has to be assessed. What are the basis for the assessment of that treatment? Of course, in research also, we take the assessment criteria after the intervention of a drug or a therapy. We are going to assess what is the impact of that intervention on the signs and symptoms of the disease. Charaka is scientifically explains there. She starts with Vikaropashamanam, then ends with Nidra Labham Yata Kale, Vaikarikanam cha Swapnanam Adarshanam. Means that when the person is treating, so after the treatment or during the treatment, if that patient is getting good sleep or normal sleep, that it is one indicative factor for the positive response of the treatment. There also the sleep will help us to assess the symptoms and it will help us to assess the effect of the treatment. Somewhere in some context, sleep or atinidra, continuous sleep, maybe is mentioned as one of the Aristotle also. Then quality of sleep. How can we assess the quality of sleep? Of course, they are the important factors for the diagnosis of the anidra or nidra nasha or nidra bhanga or insomnia, sleeplessness, whatever we talk on the abnormal state of sleep. The quality of the sleep should be assessed by the initiation of the sleep, maintenance of the sleep duration, maintenance and sleep duration, and satisfactory sleep without any disturbances. So initiation is the one factor. So usually 5 to 10 minutes after going to bed is a normal time to initiate the sleep. So if it is the thing, if it is 5 to 10 minutes, then it may be considered as the good quality sleep. And maintenance of sleep duration, of course, according to the age, the duration of the sleep differs. So usually 8 hours sleep, 1/3 of the total daytime, total day and night, out of 24 hours, 1/3 is 8 hours. 8 hours will be considered as the normal sleep time. If of course, it varies from age to age. I'm talking about an adult. So if it is 8 hours, then it is a normal sleep or good sleep, and satisfactory sleep without any disturbances. Of course, 1 or 2 disturbances may be normal. If it is more disturbances, then that quality can be it can be understood as the quality is deranged. So always, whenever we talk about the sleep or the quality of the sleep, it has to be assessed in these terms. They are the initiation of the sleep, maintenance of the duration, maintenance and sleep duration, and satisfactory sleep without any disturbances. Because why I am stressing on these 3 factors? Because they are the 3 important factors which are helpful for the diagnosis of insomnia. That is, difficulty will be there in initiation of the sleep, then reduction in the sleep time, and the more and more disturbances will be seen in the state, in a particular state. So that particular state can be taken as the nidra or anidra or insomnia. That's what I'm stressing on these three factors, and I have kept under the heading of quality of the sleep. So the quality of the sleep should be assessed on the basis of initiation, duration, and the disturbances. Then coming to the anidra or nidra nasha, what exactly the point I'm going to discuss. It is insomnia. In general, we can say it as insomnia. Let me discuss the terminologies, the meaning of different terms used for anidra to denote insomnia or decreased quality and quantity, deranged quality and quantity of sleep. It's a combination of two words, nidra and nasha. The term nasha refers, of course, I have told about the nidra already. I have discussed at length about the nidra. I would like to put some light on the term nasha here. The term nasha refers to, I have taken it Sabdastoma Mahanidhi, Kshaya. The meaning is Kshaya, Sanchiyate, Apachaya, Rasa, Adharshana, Adarshana, and Bhanga. Here, Kshaya is there. Kshaya, it refers to the quantitative things, right? So Kshaya. So 8 hours normal sleep, Kshaya maybe 4 hours, 3 hours, it may reduce to 4 hours or 3 hours like that. So the quantity derangement is there. Then Sanchiyate, so that also refers to the quantity. Apachaya, apachaya means the sleep time or the duration can be considered here. Then rasa, rasa is once again the quantity. Then the next one is bhanga. Bhanga refers to the disturbances. So the term nasha gives all the three meanings what I have discussed already in my previous slide. That is the qualitative derangement, that is the difficulty in initiation. Then apachaya or rasa is the reduction in the sleep time, normal duration of the sleep, and bhanga refers to the disturbances. So on the same, I have quoted the meaning in different heading as elimination, being lost, disappearance, or the destruction. So elimination is the reduction, being lost is also reduction, disappearance is, of course, it can be taken as disappearance, and destruction as the disturbance during the normal sleep time. Based on these information, we can say that nidra nasha is, or anidra, or insomnia, according to the principles of Ayurveda, or understanding of Ayurveda, is derangement in the quality and quantity of reference to the reduction in sleep hours, disturbance during this sleep, including difficulty in initiation. So what are the different terms used to denote anidra or insomnia in the classical textbooks of Ayurveda? Here I am just showing you the compilation. So in different chapters, in different sections, or in different diseases, a description of the diseases, these terms, these are the different terms used to denote the insomnia or deranged quality and quantity, decreased quantity of the sleep. They are anidra, then alpanidra, then aswapna, jagarana, nidra vigata, nasta nidra, nidra nigraha, nidra vibhamsha, nidra kshaya, nidra bhanga, nidra cheda, nishi jagarana, nidra viparyaya, then prajagarana, and vita nidra. So once again, considering the same previous three concepts what I have discussed, difficulty in initiation, reduction in sleep time, and disturbance during. So all these terminologies gives the similar meaning. So anidra is absence of sleep, the reduction in the sleep time. Then alpanidra is reduction in sleep time. Aswapna is reduction in sleep time. Jagarana is a reduction in sleep time. Nidra vigata, it may be taken as the difficulty in initiation. Nidra nigraha can also be considered as can be taken for the initiation or difficulty in initiation. Nidra vibhamsha is the disturbances in the of the sleep. Nidra kshaya refers to the reduction in the sleep time. Nidra bhanga refers to difference, the disturbance. Nidra vinasha, loss of sleep, reduction in the sleep time. Nidra cheda, once again, cheda refers to the disturbance. Nishi jagarana, that is the reduction of the sleep time, and whole night the patient may be in the state of awaken. The nidra viparya can be taken as, can be considered viparya, maybe refers to the difficulty in initiation. Prajagarana may be taken as early morning awaken, and vita nidra is the loss of sleep or this reduction in the sleep time. Then the term nasha, I have discussed already regarding the term nasha also. The nasha refers to being lost, elimination, disappearance, destruction. So, and by seeing the synonyms, it may be considered as the condition characterized by inadequate quality and quantity of sleep with reference to reduction in sleep time, duration, and disturbances during the normal sleep hours. That is the definition of the term nidra nasha, insomnia, according to Ayurveda. Then coming to the causative factors. So it is in Charaka Sutra Sthana, while explaining the Staulya and Kasha. There, the discussion goes like this. Atinidra may be the cause for the Staulya. Atinidra is cause for Staulya. So by considering that one, Atinidra Chikitsa has been told by Acharya Charaka. In the same context, the Atiyoga of the Chikitsas which are told for Atinidra may lead to the Nidra Nasha. Please remember this point. The Atinidra Chikitsa, Atiyoga of the Chikitsa which are done for the Atinidra may be the causative factors for the Nidra Nasha or Anidra. So I have tried to classify these Nidanas into different things. I have compiled all the things and I tried to classify it. So it starts with the Aharajanya Nidanas, Atiyoga of Rukshana Sevana, Dhumapana, Vyayama, Upavas. Here everything should be considered as Atiyoga. Atiyoga of Dhumapana, Atiyoga of Mamana, or Atiyoga of Upavasa, Kshuddha or Trishna. Then Atiyoga of the Chikitsas. So Atinidra Chikitsa is Mamana, Virechana, Shiro Virechana, Svedana, Anjana, and Langana are the Chikitsa for Atiyoga. There, the Atinidra. The Atiyoga of these Vamana, Virechana, Shiro Virechana, Sveda, etc. may lead to the Nidra Nasha, Anidra. That's what I have taken it as the Chikitsa Janya Nidanas for the Nidra Nasha or Anidra. Then this is the Manasika Nidanas, the psychological factors. Of course, I would like to comment on this. Bhaya, Chinta, Krodha, Manastapa, Shoka, Veta, Harshalobha, Buddha. These are all the things which are explained in the class. These terms have been considered as the causative factors. Manasika Nidanas for the Anidra or Nidra Nasha. Of course, as I was talking about the COVID pandemic, many people are have seen many patients post-COVID. They have some sort of fear or worry that it may be the result of this problem in future on the family. So such worries are there. Because of that, the persons or individuals may not be having sleep. Their sleep pattern is deranged because of these psychological factors. Here, when we classify or when consider these causative factors, the two set of causative factors are there. Bhaya, Chinta, or the conditions which are having the suppressed state of the mind. Then sometimes this Manastapa, the Harsha, Lobha, Gudha. So there are some causative factors which are having the anxious state of mind. So Harsha is there. Harsha may also be cause for the Anidra. I think many times we have experienced when we get the result of our examination, the whole night we may not get sleep. Because of that Harsha, we may not be sleep. That is also the causative factors. When we look into these causative factors, some causative factors are things which are resultant are the results of the rajoguna, rajodosha, and some are of the tamas. So here bhaya, shoka, data, manas, they're all the things which denotes the involvement of tamas, whereas krodha, then harsha, they may be having the involvement of rajas. That's what Charaka in Vimana Sthana, Trivida Kukshi Adhyaya, Trivida Kukshi Vimana Adhyaya, he says that Tamasaha, Manaso Doshaha, Tayor Vikaraha, Kama Krodha, Lobha, Moha, Chinta, Bhaya, Shoka, Chitta, Chittodvegadayaha, Chittodvega, Bhayadayaha, like that it goes. So the anxious state and suppressed state, both the things, both the conditions are rajasic conditions or tamasic condition. Rajodosha and tamodosha may be taken role in the manifestation of the nidra nasha. Then other causes, this abhighata and kshaya may also be considered as the other causative factors for the insomnia or anidra. Understanding the causes by the previous descriptions, we can say that, or we can classify these causative factors as chikitsa yoga janna nidanas. I was highlighting that one. Atiyoga of pamana, atiyoga of virechana, atiyoga of svedana, atiyoga of shirovidechana may lead to the nidra nasha. That can be considered as the chikitsa atiyoga janya nidanas. Then Harajanya Nidanas, Rukshanna Sevana, Ati Rukshanna Sevana, Ati Yavanna Sevana, like that. Then Manasika Nidana, just now I have discussed about Manasika Nidana. Then Anya Nidanas like the Abhighata and Kshaya. Apart from that, there are few more set of causative factors are explained by Acharya Vagbhatarya. Sattva Udaryam Tamoyaha, so Sattva Guna Bhuhistaha. So the persons who possess sattva guna more and more and tamojayaha, having control over tamo guna or tamo dosha, they will not have good sleep. I mean, they don't require more and more sleep. That is the meaning. That meaning should be considered here. They are not directly, they cannot be considered as the cause for the insomnia. They can be considered as sattva udara tamoja, a person who are having sattva guna bhuvista, having more sattva guna and having control over the tamas. They may not need more hours of more duration of sleep. Then another set of causative factors are mentioned here by Charaka. Karyakala vikarascha prakritir vayurevacha. Karya. So when the person will indulge in some work, so when deeply involved in that work, he may not get the sleep properly. Then kala, so vardakya, kalaha vardakyaha iti uchyate. Chakrapani comments on the same as Acharya Chakrapani's version on the same term kala as kalaha. During the vardakya avastha, after 60 or after 70 or 75, the duration of the sleep goes on decreasing. Then karyakala vikara, any person is suffering with any diseases, so because of the effect of that disease, he may not get the sleep. Then prakritir vayure, which vataja prakriti, usually vataguna bhuishta. So if you look into the prakriti, I mean vata prakriti purusha lakshanas, there they are alpa nidraha, so they don't require more time. So to do their routine works, they may not be in need of more and more hours of sleep. So in this manner, the causative factors for insomnia can be understood in general and in particular. Then this nidra nasha or insomnia, it is a causative factor. In the previous things we have discussed about the causes for nidra nasha. So these are the cause. Aharajanya manasika nidanas may cause nidra nasha. But in some diseases, the anidra itself may be a cause for various diseases. I have listed out those disorders. by referring the textbooks, I mean the Samhitas, Vata Prakopa with reference to Udana and Samana Vata Dusti may cause due to Anidra, Ajirna may cause due to Anidra, Vata Vyadhi may cause due to Anidra, Vata Kantaka, Rakta Pitta, Kasa, Puspa and Kshaya. Anidra may not be a direct cause, but it can be a supporting cause. There are two set of positive factors told by Acharya Shushruta. One is Utpadaka Hetu and another is the Venjaka Hetu. Usually these Utpadaka Hetus will to and Venjaka Hetu will helps to manifest the disease. So Utpadaka is production of the disease. Venjakam Vyaktata Yanti. So Dallana comments on the same as Karaka Hetus and Jnapaka Hetus. Karaka Hetus means which set the Samprapti. Jnapaka Hetu means which exhibits the Lakshanas. I would like to highlight this particular concept here to understand it in a more systematic manner. The causative factors of apasmara. So there are Mityahara, Vihara, Dushita Bhoja, Dushta Bhojana Sevana. Different set of causative factors are mentioned in our classics regarding for the apasmara. So at the end, some of the Manasika Nidanas are explained, Chinta, Bhaya, Shoka, like that. So Aharajanya and Viharajanya Nidana, they set the Samprapti, and these the Manasika Nidanas, whenever the person will come in contact with those causative facts, Manasika Nidana, immediately the Lakshana may occurs. So Shitala Vayu Sevana, Shitahara Sevana, Shita Jala Sevana are the Utpadaka Hetu for Tamakashwasa, whereas Raja and Doma Sevana may be a Utpadaka Venchaka Hetu for Tamakash. In that manner, the concept can be understood. So here, why I have taken this thing for the discussion is Anidra or Nidranasha may not be a direct cause for the Ajirna or Vatavyadhi or something. It may be a supporting factor. It may increase the intensity of other Nidanas to for the manifestation of the disease. That's what I have taken Nidranasha as a positive factor for this set of disorders. And also for Prameha, Meha, Urustamba, Vataja Shiroroga, Kash and Shota. Anidra may be one of the supporting factor or triggering factor or causative Venjaka Hetu for the manifestation of the disease. Then here I have tried to emphasize or to understand the Samprapti of Nidra, Nasha or Anidra. I have taken two components here. One is the somatic component and another is the psychological component. So Ayurveda has given almost the psychosomatic approach for the understanding of every disease. So Nidana Sevana, what we have discussed about already regarding Nidana, that the vitiation either manas or by or for the Sharira or sometimes both. So manas, of course, I have not commented anything on the Sattva. Here I have taken Sattva, Raja and Tama, increase in the Rajas and decrease in the Tamas, and in the Sharirika dosha, increase in the Vata and Pitta and decrease in the Kapha. Here always, when we talk about the Samprapti, Amshamsha Kalpana of the Samprapti, this dosha and dhatu should be understood on the basis of three factors. They are the Dravyataha Dusti, Gunataha Dusti and Karmataha Dusti. Here I have taken the Gunataha Dusti for understanding the dosha in the Samprapti of Nidranasha. Here Ruksha Guna Vruddhi, Lagu Guna Vruddhi of Vata, Ruksha Guna, Ushna Guna Vruddhi of Vata dosha, the Pitta dosha may take place, and Snigdha, Shita, Guru, Manda Guna of Kapha may take place. So because of this Vata Vruddhi, Gunataha Vruddhi of Vata and Gunataha Kshaya of Kapha, there may be chances of there will be chances of Manomoha Sroto Dusti. So because of the Manasika Nidanas, and that leads to Dhatu Kshaya. When Dhatu Kshaya occurs, the Kapha and Tamas will not be able to fill the Samyavaha Srotas. So when there is no Kapha or no Tamas, then there will not be Nidra. Vitiates the Manasthana hridaya, that may lead to the condition of nidra. And this is what I have understood the concept of the samprapti of anidra when I examined many patients who are suffering with the anidra. Then lakshanas are the parinamas. Of course, lakshanas, since beginning I am talking on the lakshanas of nidranasha, starting from its definition of nidranasha. Definition, it can be defined on the basis of lakshana only. I have taken lakshana as the criteria to define the nidranasha. Of course, different criterias are there based on nidanas. The terminologies have been considered. So, mudbhakshana janya pandu, makshika bhakshana janya chardi. There, the causative factor has been taken as the parameter for the namakarana. Here, I have taken the lakshana for the nomenclature of the particular condition. From the various references and discussions, we can summarize the lakshanas as difficulty in initiation sleep, disturbance during the sleep, and reduction in the sleep time, including the early morning awaken. So for the diagnosis, these symptoms should be there at least for 1 month. Then in Ashtanga Hridaya, Acharya Vagbhata has explained about some parinamas or effects of anidra. So there he has used the term nidra nasha. I have taken this particular term from here only, nidra nasha term. So what are the effects of nidra nasha? Nidra nasha andamardam shiro gaurva jrambikam jadya glani brahmapakti tandra rogam shavat. These are the very common features. Every person might have experienced with these symptoms. Usually during the examination time, it is my personal experience also. When we watch the cricket match, day-night cricket match in other countries like Australia and New Zealand, the cricket match starts at 4 o'clock, at 3 o'clock or 3:30 in morning in the Indian time. So when we have interest to see the cricket match, usually we go on seeing the match in the early morning, or else day-night matches. During the late night hours, we watch matches, these football matches and other things. The next day will be totally disturbed. What is my experience? I'm sharing my experience. So what are those experiences? What are those symptoms? They are the angamarda. So complete body ache will be there. Then shirogaurava, the heaviness of the head, then jrumba, the more and more jrumba, yawning, jadya, then glani, brahma, some sort of giddiness, feeling of giddiness, apakti. So the proper digestion will not be occurring, improper digestion. Then tandra, this is one of the important factor. Tandra, nidrarthas tasya seva tasatandra vinirdishi. The patient, the person will wants to go for the sleep. He will sleep on the bed. He will go to his room and sleep on the bed. Then also he may not get the sleep. So that may be considered as the tandra and other vataja vikaras. So these are the common things which we can see at the time of exam of the patient during interrogation. After assessment of initiation, duration, and disturbances, early morning awakens, we have to assess these symptoms also, these lakshanas or these parinamas of nidranasha also. That may give us the clue regarding the duration, since how many days, since what is the severity of the complaint, since how many days the person is suffering with this particular problem. So nidra nashadangamardam shirogorvajrambikam jadeglari brahmapati tandra rogashvata should be assessed properly by giving the gradations or self-gradations. Then disturbed sleep condition as a symptom in various disorders. So previously I have discussed as disturbed sleep or anidra as a cause for different diseases. Here I am talking on disturbed sleep condition as a symptom in various disorder. When we go through the different disease principles in Charaka, Sushruta, and Ashtanga, so we get the lakshanas as a disturbed state of sleep with different terminologies, what I have discussed earlier. So those diseases are, we get the disturbed state of sleep in as a lakshana in Vataja Jwara, Vatatikajajwara, Madatyaya, Dvanvaja Visarpa, Yakrat Gulma, Virakshaya, Vataja Arshas, then Tamakashvasa, different varieties of Vata Vyadi, Anatyaya, Amavata, Vataja Meha, and Vataja Krishna. Of course, these are very common disorders I have listed out here. Tamakashvasa, we get more and more cases. Amavata, we get more and more cases. So, Prameha, we get more and more cases. Then Madatya, we get cases. Many Arshas, we get more and more cases. You see the disturbed state of sleep in all these disorders, maybe because of some disturbances or mental disturbances or psychiatric, the cause. Then coming to the chikitsa, here this is quite elaborative. I would like to explain in elaborated manner here. This chikitsa, always, it's not only for nidra nasha or insomnia. In general, what I understood for the practical implementation of chikitsa, whenever we diagnose the patient, the diagnosis will be made of samprapti and samprapti ghatakas. I have highlighted the samprapti ghatakas, samshamsha kalpana, vikalpa samprapti on the basis of the dosha, dhatu, and other things. When we talk about dosha, this dosha should be understood in under the heading of dravyataha, gunataha, and karmataha. Based on that, we have decided the chikitsa siddhanta. Here, I would like to comment on the term chikitsa siddhanta as chikitsa siddhanta in Panchakarma, or for the expert of Kai Chikitsa. We have two chikitsa siddhantas. One is santarpana chikitsa and another is the apatarpana chikitsa. Eka santarpanastatra dvitiyascha apatarpanaha upakramnasahi dvitvat dvividopamamataha. So either santarpana chikitsa should be done or the apatarpana chikitsa should be done. So chikitsa siddhanta always either a santarpana chikitsa or apatarpana chikitsa. Then chikitsa sutra, that is the plan of treatment or the line of treatment. When we decide that the amavata is there, amavata is langana sadhya or apatarpana sadhya vikara. Apatarpana chikitsa should be done. So what is the chikitsa sutra? I would like to quote the chikitsa sutra explained in the classical textbooks of Ayurveda only. Langanam Deepanam, Langanam Svedanam Tikta Deepananakatunicha, Virechanam Snaya Prasteshamamarate, Saindavadi Anamasa Saksharavasti. So that is the chikitsa sutra. First we start with Langana chikitsa, then Langanam Svedana chikitsa, then Tikta Deepanakatu, then Virechana, Sneha Yukta Virechana, then Basti chikitsa. So based on the avastha, that is also very important factor to be note there, sama avastha and nirama avastha. Based on the avastha of the disease, the chikitsa sutra has to be planned. The plan of the treatment or line of the treatment should be made. So when we make all the line of treatment step by step, then the chikitsa. Here I would like to get the meaning of chikitsa is the aushadha or particular therapy. So Langana is there. Langana is the first line of treatment. So what type of Langana should be done? Either it may be a Upvasa Rupi Langana, or it may be a Deepan Rupi Langana, or it may be Pachana Rupi Langana, or it may be a Shodhana Rupi Langana. So what is that type of Langana? And if you want to do the chikitsa, what is the kalpa you are going to use? If it is Deepana and Pachana, then what is the aushadhi used for the chikitsa? So aushadha, then matra, anupana, sahapana, and atyapatya. All these things should be included in the chikitsa. So chikitsa should be planned under these three concepts: chikitsa siddhanta, chikitsa sutra, and chikitsa. This is what I understood for the treatment. Then the siddhanta, these are all more apatarpana vikara. Suitable chikitsa should be, santarpana should be, or brahmana should be the suitable chikitsa, because it is a vata vyadhi. Apatarpana vikara, apatarpana vidhanas are there. So santarpana chikitsa has to be done here. Then samshodhana, samshamana, the chikitsa sutra, what I have formulated here is samshodhana, samshamana, and brahmana, including Rasayana, preferably Naimitikara Rasayanas can be adopted here. Then Shamana Chikitsa, Acharya Dallana in the first chapter, I would like to quote once again the concept here. In Sushruta Samhita first chapter, he classifies Shamana Chikitsa as Abhyantara Shamana and Bahya Shamana. So Bahya Shamanas, what we can utilize or use for the management of insomnia is Abhyanga, Utsadana, Samhanana, Angamarda and Mardana. So these are three different treatments and they are having the similar mode of administration. That's what I have listed in the same heading. Then Akshitarpana, then Murdini Taila, Murdana Tarpana and Shiras Tarpana, then Udvartana, Shirobasti and Padabhyanga are the Bahir Paramarjana Chikitsas. Can be any one among them can be taken as the for the management of insomnia here. Many times we have seen that Bhingam Acharya Nityam Sajarasramavata Su Swapna Su Tvak Sudhar Dekrit. Swapna, it increases the sleep. Abhyanga increases the sleep. And Padabhyanga, many times we have seen that Padabhyanga is the best and important measure for induce the sleep. Then Abhyantara Shamana Chikitsas, the best. I was talking on the Rasayana Chikitsa in my previous slides when I was talking about the Chikitsa Siddhantas. Samshodhana Chikitsa, Samshamana Chikitsa, and Rasayana Chikitsa. As Rasayana Chikitsa, preferably Naimitikara Rasayana. So, what is my clinical experience is Ashwagandha Churna is best for it to induce the sleep. Ashwagandha, Anupana, Kshira as Anupana gives a better when it induces the good sleep. So, Pippali Mula Churna, the classical information it is Brahmi Churna and Shantapushpi Churna, maybe taken as the Abhyantara Shamana Chikitsa. Dosage and other things as per the Sharangadhara Samhita Madhyama Kanda, we can put in our practice. Then Ashwagandha Arista, Saraswata Arista, and Shrikandhasava may be best. And Himasagara Taila, Tundadrumadi Taila. So these are the most popular Taila preparations what we are using in our day-to-day clinical practice in the management of insomnia. So any form, Murdini Taila, I was talking about the Murdini Taila, Murdini Tarpana and Shiras Tarpana. Murdini Taila, Murdana Tarpana and Shiras Tarpana. So Murdini Taila, as per Acharya Vagbhata, in Gandusha Vidhi Adhyaya of Sutrasthana, he has explained, Acharya Vagbhata has explained about the 4 types of Murdini Taila. Abhyangaha, Sekaha, Pichavaha, and Bastayaha. Shiro Abhyanga, Shiraseka, Shiro Pichu, and Bast. So for those modalities, Murdini Taila means the application of Taila over the Murdini or the overhead in different forms. They are the Seka, Pichu, Basti, and Abhyanga may be different modalities, different form of application of oil. So we can use these Tailas based on the condition of the patient. Himasagara Taila or Tungatrumadi Taila may be the choice. They may be used for the purpose of Murdini Taila. And for internal medication, Kalyanaka Grita, whenever you feel that there is an involvement of Manasika dosha more, the Kalyanaka Grita or Brahmi Grita, based on the involvement of the dosha, you can decide. Then the Patya, in many instances, the importance has been given under the heading of food for the Mamsa and Shira Vikaras. So Gramya Mamsa, Anupa Mamsa, and Jaliya Mamsa may be taken for the food as a food for during the treatment of insomnia. And Kshira Vikaras, Mahisha Kshira, Piyusha, Kilata, and Morana. I don't want to go for the preparation of these things. Just I can refer Astangradaya Sutrasthana. There, the both Arunadatta and Hemadri have emphasized how to prepare this Piyusha, Kilata, and Morana. So Mamsa Vikaras and Kshira Vikaras and Sita has been given more importance in various contexts in the textbooks of Ayurveda. May be used as a food for during the treatment of insomnia or anidra. Then this is one of the important factors here. psychological aspects. Only treatment and only food may not be, or shamanamsha, this may not be a complete treatment. Manasika upacharas are very much important here. All the classical terms what I have taken here, manonukula vishaya grahana. So we have to discuss about the subject which are feasible or which are comfortable with the patient. Manonukula Shabda Grahana. I think many times we have seen that the patients, the people, when they are going to go for the sleep, they use the, they listen the light music. That light music well itself may be a factor to induce the good sleep. Manonukula Gandha Grahana, like that Shayya, the arrangements of the arrangement, Murdu Shayya or Sukha Shayya, that is also one of the important factor, Manasika Upachara. Then Nischinta, Chinta Tyaga, avoiding the worries, Bhaya and Lobha Tyaga, avoiding or removing the removal of Bhaya and Lobha from the mind, maybe acts as a supporting factor for our Samshodhana, Samshamana, or Bahya, Abhyantara, Shodhana Chikitsa, Rasayana Chikitsa, etc. Then other modalities, what are explained in the different textbooks are Snana. Of course, we know that Snanaha Sramaharanam Srestha in Agropyramid. So Snana relieves the Shrama. When we relieve the Shrama, then we may have the good sleep. Varsha Sevana of Varsharutu. Vastrakrita Vayu Sevana. So Vastrakrita Vayu Sevana or Kadali Patra Vayu Sevana, just it is like a fan. Usually fan, sometimes some people will have the habit of operating, I mean putting switch on the fan during this, even though it's very cold, they have the habit of using the fan or keeping the switch on the fans. So this can be taken from this particular reference, I feel. Vastrakrita Vayu Sevana and Kadali Patra Vayu Sevana. Then at the end, before concluding my talk, I would like to highlight some aspects on Sattvavajaya Chikitsa. This thing I have taken from the Charaka Samhita Sutra Sthana, Dirganjiviti Adhyaya, I mean the first chapter of Charaka Sutra Sthana. While explaining the treatment modalities for Sharirika Vikaras and Manasika Vikaras, of course, Bastir Vireko Vamaram Meta Tailam Gratam Madhu for the Sharirika Vikaras. Then Charaka Acharya has explained Manasanam to Jnanam, Vijnanam, Vijnana, Dhairya Smriti, Samadhihi. So, what are these Jnana, Vijnana, Dhairya Smriti, and Samadhi? I would like to use this particular stage to emphasize the importance of psychological I mean support or assurance or education, a proper education to the person who can come out from the psychological problems like insomnia and other major and minor mental disorders. So let us discuss these things one by one. Jnana, what is Jnana? Chakrapani comments on the term Jnana as the Jnanam, Atma Jnanam. Atma means the self, the knowledge about self. When we have the knowledge about ourselves, definitely we will not have any sort of psychological illness. Then Vijnana. Vijnana is Vishesha Jnana or the Shastra Jnana. Vijnanam, Shastra Jnanam. The knowledge about the science. Many times, I think I quote the example of Gadodvega. Vina Vyadim Vyadishanka Gadodvegam Prakirtitam. So, when we educate about that disease, definitely the person who is suffering with Gadodvega, he can come out of that problem. Then the third one is Dhairya. Dhairyam Unnatischetas. Usually, in the depressed state, the mental status will come down, the sattva bala will be less. So, what is the modality to increase the sattva bala to bring it to the normal state? That is the dhairya, assurance, courage. Another term, another meaning for the dhairya is courage. When we give assurance, definitely the person will come out of that problem. Then smriti. So smriti is the memory. So what is the meaning of memory? There are three important modalities or medias are explained by Charaka in Sharirasthana first chapter. What do you call that? Drishta Shruta Anubhutanam Smarana Smrtiruchyate. So Drishta, Shruta and Anubhuta, recollecting the things which we have seen, that is the Drishta, seen in the past, which we have heard in the past, and which Anubhuta, which we have experienced in the past. Here, what I would like to apply this Smriti as, advise the patient to recollect the good memories and forget the bad memories, right? Recollection of good memories may helpful for उसको mic on करो. Recollecting the things, good memories, may be a good cause for having the good sleep. Then the last one is samadhi. Samadhi is yoga abhyasadinam manasoho niyamanam. By adopting or practicing the techniques of yoga, definitely we can come out with the problem. So these are, of course, usually when I tell to my students, when I take the Panchakarma classes, Pamana Virechana, Basti Nasa and Rakta Mokshana are Panchakarmas for the Sharirika Vikaras, whereas Jnana Vijnana Dhairya Smriti Samadhi are nothing but the Panchakarmas for Manasika. This is my opinion. Panchakarmas for the management of Manasika Vikaras. So in treating the condition of insomnia, these Dhyana, knowledge about self, Vijnana, the Shastra Dhyana or education, Dhairya, assurance, Smriti, recollection of good memories, and Samadhi, practicing the yoga may be a very, very beneficial modalities to induce the good sleep. With these lines, I would like to thank the organizers for giving me an opportunity for presenting my views on the context of Anidra. And at the outset, I am also very much thankful to my guide, my teacher, Professor Ajay Kumar Sharma sir, former director, National Institute of Ayurveda Jaipur. Because of his blessings and because of his guidance, I'm here today. With most respect, I thank my teacher Ajay Kumar Sharma sir, and also I'm very much thankful to the director of National Institute of Ayurveda Jaipur. Special thanks to my principal, Dr. Prasanna and Rao, for encouraging me to speak in this stage, and my special thanks to Dr. Ved Patak, Surendra Ved Patak, and to whole team of Panchakarma department and the technical team for supporting me. My wholehearted thanks to all the team. With these lines, I conclude my presentation. Thank you one and all.
Thank you very much for such an informative talk and kind words for us. I may now request the learned audience to text the query to Jara sir. With this, I would like to initiate the question and answer session. The session coordinator for this session will be Dr. Vaibhav Bapat, Faculty of PG Department of Panchakarma NIE. Handing over platform to you, sir.
Thank you, ma'am. First of all, I want to thank of our guest speaker for such a brainstorming and informative speech. Pujara sir, can we start with questions?
Yes, sir. Please, you can.
Sir, first question is, what is the treatment for excess dreams or swapna during sleep?
What is that, ma'am? Can you repeat?
What is the treatment for excess swapna or dreams during sleep?
Yeah, swapna or dream is a condition. There are two stages of sleep when we go to the physiology of sleep, as according to the modern medicine or modern psychology, psychiatry. Rapid eye movement sleep and non-rapid eye movement sleep. So initially the sleep starts with rapid eye movement sleep, and after some times the person will go into the non-rapid eye movement sleep. So this cycle of rapid eye movement sleep and non-rapid eye movement sleep is called as the sleep cycle. During the non-rapid eye movement sleep, usually the dreams occurs. Usually after going to the sleep and at the time of awakens, we get the sleep. So to have a relief from the sleeps and I'm sorry, the dreams, the best modality is what I have explained about the different techniques of Sattva Vijaya Chikitsa. So think positive, think good during the sleep. Definitely, we will have a pleasant sleep. That is the only one thing what I can say. Other modalities, as a Bahir Parmarjana Chikitsa, what I have experienced, it's my personal experience that when we do this Padabhyanga during the night time, we get a good sleep. We will have a sound sleep. There will not be a disturbance due to the or uninterrupted interruption due to the dreams. That's what I can. What Sattva Chikitsa and Vairupamardana Chikitsa may be helpful for the dream disturbance during the normal sleep wake cycle. Over to you, sir.
Thank you, sir. And another question is, sir, if we are planning any kind of Shirodhara, Shirobasti, Shiropichu in case of COVID positive cases or post-COVID management, then what should be the ideal protocol for that?
Of course, it's a very good question. During the COVID-19 this thing, almost Panchakarma protocols, Panchakarma guidelines have been released by various government and non-government organizations that we have to follow. So usually, what is my personal opinion is, during the treatment for COVID, sitting that today I have my RT-PCR result has come positive and I have been home isolation is isolated or I have been admitted in COVID care centers or in quarantine centers. So during that time, we can advise if there is no any sort of lakshanas like fever or lakshanas of cold and sinusitis, if asymptomatic, then we can advise the Padabhyanga only, sir, because there will not be much difficulties with Padabhyanga. When we come out of the COVID protocol treatment protocol, then if symptoms are not there, definitely we can start the treatment of Shirodhara, Shirobasti and other things by using the COVID protocols like the what we call that hand hygiene, respiratory hygiene and other things. It is better to avoid during the pandemic. So ask the patient to go for self-administration of Adabhyanga and Shirobhyanga with the tailas, preferably the Himasagara taila or Tungadrumadi taila, what I have explained. Or else anything is not available, if they are not able to go outside or then purchase the taila, ask them to use the coconut oil, which is available, of course, in South India. Every house coconut oil is available. Ask the patient to do the Adabhyanga and Shirobhyanga with the same coconut oil. So that can be managed in that aspect, that manner during this particular COVID pandemic times. Over to you, sir.
Okay, sir. Thank you. And one another question, sir. In if we think in perspective of Ayurveda, then how much quantity? What should be the quantity of sleep according to perspective of Ayurveda?
Of course, when we look into the basic principles, Sankala has been told as is considered as the time for food. Usually, Sankala we consider during this time we consider 7 to 7:30. It's a Sankala, and other classical textbooks explains about in Dinacharya Brahmi Muhurte Uttishta. So the duration between the last yama of the Sankala and Brahmi Muhurta. So 7:30, 7 to 7:30 or 8 o'clock is the maybe considered as a last yama of Sankala, and Brahmi Muhurta is 4 or 4:30. So that much of duration can be considered various. I am telling may be considered as the normal duration of sleep. Roughly, when we calculate it, it comes around 7 to 8 hours. Sometimes it is 8 to 9 hours based on the variation of the sleep. So 8 hours or 8 to 9 hours may be considered as the normal sleep duration, which is very much essentially required for an working adult, sir. Over to you, sir.
Okay, sir. Thank you. And last one question, which is I think continuing to this, and which is very much interesting question, that is there any relationship between sunrise and Diwaswap? I think participant want to question that if we are everyone of we are doing a Diwaswap because we wake up after sunrise. So please elaborate this, sir.
Of course, Divaswapna is what I feel is Divaswapna is the sleep during the daytime. So when we start it from night time, if we wake up in the later morning hours, it may not be, my opinion is, it may not be taken as the Divaswapna. Divaswapna is that after waking up and after doing all our works, during that daytime, we go for sleep, then it may be considered as Divaswapna. So wake up at 6:30 or 7 o'clock after sunrise. I think it may not be suitable as the Divaswapna.
Okay, sir. Thank you very much. Our second guest speakers is Dr. Shibu Varghese. Now he is busy in his OPD and cannot attend this session, but he replied that he will answer all questions through his WhatsApp or mail. Then I request all participants, those who have question to Professor Shibu Varghese sir, they can send their question to his WhatsApp number or send to us. We'll try to reply them with their particular mobile number or email ID. Thank you very much, sir. Over to you, madam.
Thank you very much, sir, for coordinating this session. Now, I would like to pass the platform to Dr. Rupesh Mangal, sir, Associate Professor, PG Department of Panchakarma, NIA, for delivering vote of thanks. Over to you, sir.
Thank you, madam. Thanks a lot. Honorable Director, sir, distinguished guest speakers, and dear participants, on the behalf of PG Department of Panchakarma, NIA Jaipur, I feel immense pleasure to take this opportunity to propose vote of thanks to eminent Ayurvedic scholar Dr. Shibu Varghese, HOD and MS Naval Ayurvedic College, for taking out time from his busy schedule and sharing knowledge on radiological diagnosis of spinal disorder management by Panchakarma, with special reference to Hastavaidya practice, which is a very famous and extremely important practice of Kerala. Further, extend my hearty thanks to Dr. Muralidhar Purja, Professor and Head, PG Department of Panchkarma, SDM Ayurveda College, Hassan. He has given an elaborate session about the management of sleep disorders with special reference to insomnia. We sincerely thank you for being with us and enlighten our knowledge, sir. I take this opportunity to especially express my deep regards and gratitude to Professor Sanjeev Sharma, sir, the Director of NIA, for always encouraging us and providing opportunity to organize such event. I would also thanks to our HOD, Dr. Surinder Ved Pathak, sir, for their valuable support all the time and confidence in us. And also thanks to our organizing team for their precious support and excellent coordination. Furthermore, great appreciation should be given to our PG and PhD scholar of PG Department of Panchakarma for their great efforts to make the event successful. I also thanks to our IT team of NIA. Without their technical support, this event is not possible. Last but not least, I am very glad and thankful to all participants for their valuable presence and support is highly appreciated, and hoping the same response from your side for the future webinars. Once again, I thank you all for being with us this afternoon. Have a wonderful day. Thank you. Jai Bharat, Jai Ayurveda.
With this vote of thanks, I would like to announce the completion of our national seminar. But prior to that, we would recite the Shanti Mantra, following which the guests are requested to leave the platform. And lastly, we are highly obliged to all of you for your precious presence. Thank you.
ॐ पूर्णमदः पूर्णमिदं पूर्णात् पूर्णमुदच्यते पूर्णस्य पूर्णमादाय पूर्णमेवावशिष्यते ॐ शान्ति शान्ति शान्तिः